I'm David Seltz. I'm the Executive Director of the Health Policy Commission. Seated to my left and to my right is the Board of the Health Policy Commission and representatives of the Center for Health Information and Analysis and the Attorney General's Office. For those of you who were with us yesterday, either here in the room or on our live stream, welcome back. For those of us who are joining for the first time, I'll just go through a few logistical reminders. One, this entire event is being live streamed and will be placed on YouTube for posterity. Two, we do have Wi-Fi available in the building. The password is on the back of your program materials. And third, we do want to engage with you and a broader public through social media. So please tweet at us and tweet this event at #CTH. Yesterday, we engaged in a lively and constructive conversation with our invited speakers, invited experts, and invited witnesses on some of the most significant challenges facing our healthcare system. We talked about the progress that we had made in some areas and the lack of progress we had made in others. Today, we'll dive deeper into some of the themes from yesterday. Yesterday, Chairman Jeff Sanchez challenged us to look beyond the acronyms and the jargon and to keep the patient at top of mind. Continuing that theme, this morning we'll be discussing innovative, patient-centered models that address the social needs of patients with the goal of better health and lower costs. We'll also engage directly with a reactor panel of organizations and individuals that advocate on behalf of the patient and family voice in healthcare transformation efforts. Yesterday, we also heard from Governor Baker, who made the case that speeding up FDA approvals for generic drugs could contribute to a more competitive pharmaceutical market. This afternoon, we'll engage with payers, providers, and a representative of the pharmaceutical manufacturing sector to discuss other potential solutions to addressing the rising costs of pharmaceutical drugs while maintaining incentives for innovation. A few final agenda notices. We do have a new witness on our first panel today. Frederica Williams was unable to join us, so we're pleased to have Manny Lopes, who is the CEO of East Boston Community Health Center, joining us. Also, you may have noticed that we have a poster here in the room that includes an infographic. This was drawn from our pre-filed testimony that we collected from payers and providers prior to the cost trends hearings. A summary of that pre-filed testimony is also included in your program books. The infographic and this summary will be made available on our website. And finally, I want to recognize some individuals who joined us yesterday. Representative Christine Barber was here, engaged in the conversation. We also had Roberta Herman, who is the Executive Director of the Group Insurance Commission, was here yesterday. We have so many members of the HPC Advisory Council here. I won't even be able to list them all, but thank you for being here. And then finally, again, so many staff from legislators in both the House and Senate. Thank you for joining us as part of this conversation. So with that, we'll turn it over to the Chair of the Health Policy Commission, Dr. Stuart Altman.
David, thank you. I think you did a great job in summarizing what we talked about yesterday and are going to talk about today. I just want to add one or two statements because I see our Senate President here and I know how busy he is, so I'm not going to spend very much time. I think the focusing on the issue of social determinants is particularly important in this environment. Recently, I've been struck looking at spending in the United States in comparison to other countries and the fact that on many dimensions we just don't do as well. And some of us have been more than a little critical about our healthcare system in terms of why we spend so much and don't do well. Well, I'm here to collectively apologize to the healthcare community. I think the criticism is legitimate, but it's not. It's aimed the wrong place. I think where we really fall down in America, and the statistics show it, is what we spent on social issues that relate very much to health. And that when you look at what we spend in healthcare and how we use our healthcare system, sure, there are things we don't need to do, things that we do that are bad for people's health. But where we really fall down is in the area of social services. And I'm particularly pleased with the set of presentations we're gonna have today on that subject. And I'm particularly pleased with the discussion we had yesterday, where these new forms of delivery system on the healthcare side, ACOs, bundled payments, and the like, really are being, for the first time, well, not the first time, but again, giving the incentives to our healthcare community to think more broadly about health. So I look forward to today. We also are going to grapple again with the issue of pharmaceutical pricing and availability of services. We all want more, better drugs. We're very concerned about their costs. So again, I look forward to that discussion as well. And I'm sure we will have several others that will temper it. But let me now turn to, again, as I said yesterday, I have the best job here. I get to introduce people who, not only do I get to introduce them, but such respect that I have for them makes the job so easy. And nothing better than the ability for me to introduce our Senate President. Senator Rosenberg came to prominence on the Hill in 1986, and he has just moved up in the system. I've had the pleasure of getting to know him, and we've been on several programs together, and I can't think of a better person to be running the Senate for our great Commonwealth. So let me now introduce our great Senator and our great President. Thank you so much for coming.
Through you to the members of the commission. First, thank you for offering this opportunity each year for this set of hearings, a day or two or three, however many you do, to provide the opportunity for the public to understand the work that you're doing. It's just so critical, this work that was set up by Chapter 224, to be able to provide an opportunity for some of the best minds in the Commonwealth to sit around a table and try to find common ground to address the questions that relate to the cost of delivery of health care and the disparities in our system, so that we end up with a better opportunity for people to get the quality care that is available in this Commonwealth with our amazing collection of research and teaching hospitals, our universities and colleges, and all of the other institutions that have developed around them that allow for medical breakthroughs, medical devices, pharmaceutical industry, all of those pieces that together constitute a complex here in this Commonwealth, which is really second to none anywhere in the world in terms of the ability to create new groundbreaking treatments and strategies for dealing with disease, and also public health, so that we can work with all of the entities in our community that can help us help prevent disease, but then also help make sure that where disease presents itself or health compromises need attention, that we have the best services available. So with that, I want to join the chorus again this year. I came before you in the past and said that the number one concern on my mind was the cost of pharmaceuticals. I've been filing legislation for more than a decade, trying to figure out a path for aggregation of demand right here in Massachusetts, and to see if we could replicate what's going on in some other parts of the country. We have a two-state collaborative up in the northwest part of the country, which has produced very significant savings and results for the people who participate in that program. We know that other states have come together in other regions. We know that many of our healthcare providers are part of aggregations that are actually outside of the state because that's what's available to them. But but I'm hoping that we can redouble our efforts, and since everybody is now finally singing the same tune, that pharmaceutical costs as a major cost center and cost driver of our system, with double-digit increases year after year after year, although those are life-saving and life-improving treatments, they are causing enormous problems in our healthcare system in terms of balancing the budgets of the entities and institutions and the individual home budgets and business budgets of folks all across the Commonwealth. So I want to commend you and urge that you play as large a role as you can in this, and I've had conversations with a number of folks in the last 4 or 5 months who may on the outside be willing to be partners with HPC and others to see if we can once and for all bring people around the table and identify some bold initiatives that could help us address this. The drivers, both the new drugs that get created and even the drugs that go generic, are increasingly becoming more and more expensive. And I was glad to hear that the governor said yesterday that he's hoping the FDA's quicker action by the FDA might produce results. But that said, we don't control the FDA, so we have to look in our own backyards and figure out what it is we can do here to try to address the pharmaceutical problem. It's also a couple of themes that have emerged recently. A transparency in the methods by which drug pricing is established might provide some new information and a new theme or a new thread that we could try to pursue here in the Commonwealth, even as we continue to think about and hopefully finally find a path forward on some form of aggregation. Secondly, I wanted to comment that some of you may be familiar with the study that was done with the help of the Milbank Fund out of New York, which is a foundation that supports public health research. We sent a team of 8 senators off to Colorado, and they met with folks from Colorado and Washington State, who were the 2 states at the time that had legalized recreational marijuana. And they came back and wrote a 120-page report, which is now being used fairly extensively in the debate on the ballot question. Well, we started thinking about 6 or 8 months ago about the question of whether we could launch another initiative with the help of the Milbank Fund, and they have agreed to work with us. And we've had some consultations with David on behalf of the HPC, also with Secretary Sutter's staff, and also with Dan Tsai, to identify some of the cost centers here in our healthcare delivery system in Massachusetts that could use a deep dive and see where we might find states that have best practices and see if what they're doing might be transferable to the Commonwealth of Massachusetts. And so we have now identified a team of folks. We've identified a list of 4 or 5 areas that we're going to look into, and we've identified a team of folks who are going to travel to some other states, and also we will invite people from some of those other states here so we could have an even broader conversation and more people could be involved than just those who are traveling to the other states. So I'm hoping that things like pharma, behavioral health, and physical health, the work that's going on and trying to blend those two, also looking at inequities, social inequities and factors in our delivery of health care, and also long-term care. I think those are the 4, and pharma, those are the 4 or 5 major areas that we're going to look into. And so I'm hoping that by the time you convene next year, that we will have a deep dive on some best practices in some of the other states to see enter into the dialogue here in the Commonwealth in terms of you're doing a lot of work on sort of the big picture. You're drilling down in some areas that are brought to your attention. These areas, we are hoping, by identifying best practices in other states, might inform the conversation here and lead to legislation and other policy actions that could help make a big difference in our work here on cost containment. So again, I want to thank and congratulate all of you for the time and effort that you put in and the contribution you're making to help us deal with this enormously challenging area of policy, because it is, as I say, one of our 5 largest industries, and we need to make sure that we don't do anything to chill our ability to provide the very best access to the very best quality healthcare anywhere in the country. But we also have to be mindful that this is an industry employing a lot of people, and we need to make the right decisions and make the right moves so that we can ensure that our healthcare dollars are being spent wisely and well, and that we continue to support appropriately the industries that are part of that very large complex of entities that form our healthcare industry. So with that, I thank you very much for the opportunity again to present to you this morning, and I thank you for this opportunity, and I wish you great success in the remainder of today and the work that you will do until next we gather.
Mr. President, thank you so much. This is great, and we really appreciate all the help we've been getting from your office and you yourself. The areas that you touched on really resonate very well with all of us. I'm particularly impressed and would like to work as closely as we can on this idea of seeing to what extent there are other activities in the United States and other states that we like to think we're ahead of most states, but it's a little, we should be a little humble that not all the good ideas come out of our state. There may occasionally be something going on that we could learn, so I couldn't agree more.
And maybe in some instances, we'll find out and validate that we are the best.
I do say that when I go around. People don't want to hear it, but it is true. So thank you again. This is a pleasure for you to come before us, and we look forward to your coming next year. Thank you so much.
Very much.
Don?
Hi, everybody. It's a great honor for me to get to introduce our next speaker. I am the Attorney General's appointee to this commission, and I feel very proud to serve in that role, in large measure because of my enormous respect for our Attorney General, Maura Healey. Attorney General Healey was the chief of the Attorney General Office's Civil Rights Division before she was elected as AG. She had a long track record of a distinguished service challenging the Federal Defense of Marriage Act. She was chief of the Public Protection and Business and Labor Bureaus before she became Attorney General. And she works very closely, her staff work very closely with the Commission on issues related to protection of consumers and the healthcare costs that we're focused on. I just want to say personally, I have the privilege of working with many public servants, but none exceed Attorney General Healey and her courage, her willingness to speak up for issues that really matter, even at taking risks doing that. And I feel very, very privileged to be able to represent her office here on this commission. Attorney General Healey, welcome to hear from you.
Good morning. Good morning to all of you. Thank you so much for that introduction. Don, to my colleagues, I just want to tell you how much I appreciate the opportunity to be with you. I thank Senate President Stan Rosenberg, Mr. Chairman, Madam Vice Chair, Secretary Sutters, Secretary Lepori, and all the commissioners represented here today for the terrific work that you all do. I also want to thank our Executive Director of HPC, David Seltz, and Ray Campbell of CHIA, and your entire staffs and teams for the work that you do, particularly for the work that you have done in preparing for today's hearings. Good morning to you, Mr. Chairman, as well. In many ways, our healthcare system in Massachusetts is a model for this country, something to be celebrated, and the work done over the many years to get us to that point is really remarkable. We have some of the best providers and health plans in the entire world. The healthcare research, biotech, and life sciences industries based here not only drive our economy, but drive a global economy. Our universities and medical institutions make Boston a global destination for both the brightest minds in the world and those most in need of cutting-edge treatments. These institutions indeed raise the quality of our lives, and they give us peace of mind. I know whenever I get on a flight out of Logan, I take comfort in the fact that undoubtedly there is a doctor on board. Now, if you or a loved one is ill, you live near the greatest providers on the earth. Our system, anchored by stellar providers and plans, is also supported by an incredibly engaged community of advocates, scholars, and policy experts. We are so fortunate, and I think nowhere is that better represented than in the room today. We come together at these annual hearings to drill down on serious questions and to not be afraid to tackle serious and complicated challenges. What's really driving healthcare costs? What's working in our system? How should we plan for the future? Now, together, collectively, we have taken on an awesome and important shared responsibility to make healthcare accessible and high quality for everyone in Massachusetts. That alone is pretty incredible, and I don't think there's another state where there's a discussion going on that's as advanced, as informed as the one that we're having here today. But we also know that we have a big job ahead of us. We know that too many working families and small businesses have seen their premiums climb over the past year, even while deductibles and co-pays have increased. I didn't have the opportunity to be here yesterday, but I know there was considerable testimony about what's happened in that space. We know that 1 in 5 adults in Massachusetts report having medical debt. 1 in 5 in Massachusetts have medical debt. And that 1 in 5 in Massachusetts with insurance are delaying or foregoing care because of cost. Now, we can't forget, health care is only accessible so long as it's affordable. Now, at the same time, it's our job to ensure the sustainability of our providers who are under intense pressure to reduce costs. I know that if one of our goals is to stay the best in the world, then we have to compete with the best in the world as well. We know our academic medical centers face intense pressures from national and international institutions. And our community hospitals face different challenges of their own, outlined in the HPC report earlier this year. That's just one of the many, many reasons why it's so important that we come together as a group. Today, the team from my office, Assistant Attorneys General Eric Gold, Steve Vogel, and David Brill, will present on the second of 2 reports we issued as part of this hearing. But before I turn it over to them, good morning, gentlemen, I just want to share a few thoughts about our work and about what it maybe suggests in terms of how we can fulfill the promise of a healthcare system that is affordable, accessible, and ultimately, importantly, sustainable for all. First, our healthcare spending should be transparent. This begins with understanding exactly how much we're spending on big-ticket items, including prescription drugs. Here in Massachusetts, the HPC and SHIA have documented double-digit pharmaceutical spending growth annually since 2013. Given the complex rebate and discounts involved in drug price negotiations, it's been difficult to accurately study overall spending and spending trends. For the first time in Massachusetts, my office has analyzed the actual costs of prescription drugs for the major health plans after factoring in discounts and manufacturer rebates. And you're going to hear more about that today. But we think that's an important conversation to have and something important to look at as we really truly try to understand what accurate pricing is and what accurate costs are. The data show that even when you include these rebates, the growth in health plans spending on pharmaceuticals has been substantial. This includes spending, of course, on specialty drugs, vitally important medicines used to treat chronic diseases like cancer, hepatitis C, neurological diseases, HIV, and others. These drugs are doing incredible things to improve patient well-being and to save lives. It's hard to overstate the hope and the expectation we placed in this area of medicine. You will hear from my team in a few minutes about the analysis we conducted on specialty drug reimbursement to help us better understand the spending in this area. Our goal here is simple. We want to invite the next phase of dialogue, ongoing dialogue, with the benefit of additional data and information. We look forward to hearing from all the witnesses today and to working together. Our solutions must promote access to vital treatments for all Massachusetts residents, and they must support our state's continued leadership in biotech and drug innovation, a sector that I believe is central to our region's future. The second thing I want to comment on is something that you heard testimony about yesterday, and that is my belief that our healthcare spending needs to be fair. This is a matter of equity. As you heard yesterday from my assistants, Emily Gabral and Sandra Walensky, back in 2011, the Attorney General's office studied healthcare spending by zip code to better understand whether there were in fact differences in how much we spend on patients depending on where they live. We analyzed healthcare spending data for the commercial market and then controlled for differences in patient sickness, actual health, to get a fair comparison. Across all major health insurers, we found that we spend more on healthcare for wealthier communities. Now, that was 2011, and we did another look at that this year. We updated this analysis this fall and found the same results. 5 years later, we are still investing disproportionately in the health care of residents of higher income communities. This finding presents a stark challenge to all of us as we work towards a fair distribution of healthcare resources in Massachusetts, where the money spent on your healthcare should track your health needs, not your zip code. Now, we know there are many factors that may be driving this spending disparity, including greater economic, social, linguistic barriers that lower income populations face in addressing healthcare, as well as the variation in the prices of healthcare providers that different communities use. More work is needed to be done to unpack these factors and the effect of these spending disparities on the health of our communities. Responsive strategies may come, in fact, from outside of the healthcare market, okay? Outside of the healthcare market. You talk about needed improvements in transportation, housing, implementation of policies like paid sick leave. All of these factor into the foundation of one's basic health. I know part of today is devoted to hearing from national experts on this topic, so I'll close my remarks by offering just a few more thoughts. Simply put, we need to be more comprehensive, more holistic in how we think about healthcare spending. We know that smart spending can't just start at the pharmacy or at the doctor's office. Social and environmental factors do indeed contribute to or detract from the health and healthiness of our communities. These social determinants of health include the safety of our neighborhoods and access to food and housing and transportation. Because if you can't get to the doctors, you're not in a good position. These are the basic building blocks to healthy living, and they shape a community's health outcomes long before patients ever enter the healthcare system. We know that safe housing saves lives. We know that front-end investments reduce health disparities in underserved populations and lower health care costs. While housing saves lives, so do things like safe needle exchanges, programs that reduce HIV transmissions. We know that clinical social workers working with at-risk families reduce things like gun violence. We know from our own work in the Attorney General's Office on Violent Prevention, like our Game Change program with the New England Patriots, our work on the opioid and prescription drug use and abuse prevention, and our work improving housing opportunities and environmental conditions through programs like our Abandoned Housing Initiative, where we actually get in and clean up abandoned and blighted properties and turn them into housing available many times for first-time home buyers. These things matter, and they're just part of the tools in the toolkit that I believe we can and should employ as initiatives that are going to improve the overall health and well-being of communities, particularly communities who seem to be at the low end in terms of being able to access care, and certainly seem to be differently situated in terms of actual health comes right now. So these things are important. It's important as we look at something like the Department of Public Health's recently announced changes to its DON program, that it's going to focus on directing community-based health investments to address statewide health priorities. This is important work, and again, part of, I think, the fabric that we can put together to get at some of the social determinants of health and make the needed changes. I come to this as, once upon a time, a civil rights lawyer, and I think this is a matter of equity. I think this is a matter of fairness. We live in a great and wonderful state with wonderful minds, wonderful intellect, wonderful institutions, wonderful providers, wonderful plans. But we also have a wonderful opportunity to do right by every resident of the state, regardless from where they hail. So I hope it is in that spirit that we can work to bring a focus on that, and certainly my office continues to stand and will stand in partnership with all of you and with stakeholders across this state to work to that more fair, more just outcome. I thank you very much. It's always an honor and a privilege to be before you.
Oh, thank you. Well, if you gentlemen would join us, that would be great.
Chairman, I'm so sorry. I rudely just left the stage without without giving you a hug.
Hey, I wasn't going to lose that opportunity.
But I thought I'd tell you who's before you,
That would
offering
be great.
testimony
All
on
right.
behalf of our office.
All
How's
right,
that?
that'll be great.
Okay. So before you today, presenting on the second report issued by, the second report issued on behalf of our office, we have Assistant Attorneys General David Brill, Stephen Vogel, and Assistant Attorney General and Deputy Chief of our Healthcare Division, Eric Gold. Thank you, gentlemen.
I was going to warn them that they have a tough act to follow. If they do half as well as your group yesterday, they're going to do fantastic.
Oh, yes, well, thank you, Sandra and Emily.
All right, I will now turn it over to whoever's going to start.
Thank you. Thank you very much, Attorney General Healy, Chairman Altman, Commissioners. My name is Eric Gold. I'm an Assistant Attorney General and the Deputy Chief of the Healthcare Division. We'll be, along with my colleagues Steve Vogel and David Brill, talking to you for a few minutes about our work on prescription drug costs this year. So as you heard yesterday, our office has unique subpoena authority, and we've used that authority going back to 2010 to examine market trends and report our findings. One of our two reports this year is focused on prescription drug costs, and that's the report I believe you have in front of you, and what we'll be talking about for a few minutes this morning. We focused our examination on prescription drug costs in three important ways. The first is that we focused on specialty pharmaceuticals, and we did that because specialty are such a large part of prescription drug spending, about a third of all prescription spending in 2015. We also focused our examination on commercial spending. We did that because we know there's a lot of people, public payers mostly, doing very good work examining public spending on prescription drugs, and wanted to provide that same level of transparency in the commercial space. The third area of focus was on pharmacy benefit. We know, and you know too, that there's substantial spending on prescription drugs through health plans' medical benefits. We heard that yesterday from a variety of providers. But we wanted to focus on pharmacy spending through the pharmacy benefit that allowed us to do a deep dive into one focused area. So that's what we've done. There are three questions that we examined. The first is, what are the overall trends in drug spending when you include manufacturers' discounts and rebates? The second question is, how do health plans manage their pharmacy benefit? Again, focusing on specialty pharmaceuticals. And this means looking at contracting to see which organizations, the pharmacy benefit managers, the health plans, or the pharmacies are responsible for which aspects of reimbursement. And third, we undertook a case study to examine how have these approaches impacted drug pricing in one high-cost specialty drug area. And we selected MS for that case study. So turning to the first question, this is a chart that you see in our report, shows total commercial pharmacy spending trend per member per month for the last 2 years, both including rebates and without rebates. And you see we collected data from 5 health plans. If you look, we did weighted averages in the 6th line down, which is what I'll highlight. And you can see from 2013 to 2014, again, these 5 plans account for about 75% of the commercial market. Between 2013 and 2014, for the averages, you have 14.6% pre-rebate and then 13.7% net of rebate. Again, average for 2014 to 2015, 8.2% pre-rebate, 6.1% net rebate. I think for us, the key findings from this slide are that the rebates do matter. The trend is less with the rebates than without. But even with the rebates, that is net of rebates, the upward trend in spending per member per month has been substantial. I'll note a few of the individual plans. Plan 1, for example, in 2013 to 2014, pre-rebate trend was 14.3%, net of rebate 12.9%. In 2014 and 2015, the Plan 2, note that its pre-rebate trend was 14.6%, and its net rebate trend was even higher, 15.3%, suggesting that its rebates did not increase at as fast a rate as its list prices did, so it cannot keep up. The net rebate trend is larger than the pre-rebate trend. This next slide reports essentially the same data, but focusing only on specialty pharmacy instead of all commercial spending. And again, the key takeaway here is that the trends are even higher. You can see the average net rebate from 2013 to 2014 for specialty is 38.3%, and then for 2014 to 2015, 21.4%. Again, those are including rebates where they were available. One point not on this slide is that for the 5 plans we studied, and we highlight this in our report, specialty contributed at least 60% of the growth trend in between 2014 and 2015. The large share of the growth is in specialty pharmaceuticals. So moving from the annual growth trend, including rebates, we looked at how the plans approach contracting for specialty drugs. And this chart just tries to summarize our findings, which show that the plans are doing so in a variety of ways. We think traditionally that a health plan will retain a pharmacy benefit manager who negotiates with manufacturers for rebates and then for pharmacies for discounts on the front end. What we see of the 5 plans that we studied, only Plan A did that. On the other hand, Plans D and E negotiate directly with manufacturers for rebates and directly with pharmacies for discounts or manufacturers for discounts. They don't use their PBM at all for specialty price negotiations. On the other hand, plans B and C are somewhere in the middle, also using unique methods for identifying and determining reimbursements for pharmaceutical prices. So,
Thank you, Eric. The next slides discuss how these contracting practices affected prices in our case study of multiple sclerosis drugs. This first graph shows the net prices paid for one of the 10 drugs that we examined. You can see a bunch of colored lines. Each colored line shows the prices paid by one of the health plans for this drug over 5 years. And you can note two obvious trends. First, all of the colored lines increased from around $3,000 per month to around $5,500 per month. This shows a steady and substantial price growth. Second, the colored lines are very close together. This means there was very little variation in prices paid by the plans. The charts for all 10 drugs that we examined in this therapeutic area are quite similar. The tables on this slide support the graph on the prior slide. These tables translate the price growth and lack of variation into numbers. The table on the left shows the average annual growth rate for all 10 drugs at each plan. All 5 plans saw average price increases over 10% each year for 5 years. The table on the right shows price variation among the plans for each drug. We show this using a statistic called coefficient of variation, or CV. This measure compares prices paid to the mean price paid for each drug. Low CVs mean minimal variation. Here, all drugs had CVs of about 5% or lower. These are remarkably small numbers. This means there were very few differences among the plans. This next graph shows each plan's relative spending on each of these drugs over 5 years. Each bar shows one plan spending across these drugs and totals 100%. Each color represents a different drug. For instance, the very light blue at the bottom of each bar is one drug, Copaxone 40 milligrams, and the small olive green slice at the top of each bar is for a different drug, Obagia. What you see is that the bars look alike. The relative spending on each drug is quite similar. We think that this likely explains why price growth has been so similar across the plans. They cover all or nearly all drugs in this therapeutic class and do not meaningfully use common strategies to limit spending, such as formulary tiering or drug exclusion. Why might this be? Our examination showed that providers, patients, and plans share a clinical view that it is necessary to have access to all of these drugs, even though they all have the same indication. Different drugs are effective for different patients at different times, and it can be difficult to predict which patient will respond to and tolerate each drug. We will come back to this point in our recommendations. One final thing we sought to examine is the impact of the entry of the single generic drug in this class. This chart shows the overall utilization of 3 drugs. In blue, the original product, 20 milligram Copaxone. In green, a new formulation for Copaxone, 40 milligrams, introduced in 2014 in advance of generic competition for the original formulation. The new formulation had a real clinical benefit, 3 injections per week instead of daily injections. And in red, you see the generic version of the original daily injection version of Copaxone, called Glatopa. It came on the market in the second half of 2015. You can see that utilization of the new formulation, the green line, increases rapidly upon market entry. At the same time, the blue line, use of the original formulation, decreased substantially. The red line at the right of the graph shows the introduction of the generic. At the time of generic entry, the vast majority of existing prescriptions were for the new formulation of Copaxone. Thus, there were not many patients left on the old formulation who could switch to the new generic. The low utilization of the old formulation meant that it was unlikely that generic entry would lead to a material decrease in overall spending. Turning now to our recommendations. We have 4 that we would like to discuss. The last 2 are related, and I will deal with them together. In general, we have tried to focus on actions that we can take here in Massachusetts. We, of course, recognize that the federal government controls other levers that are equally or more important in influencing drug pricing. Our first recommendation is transparency. Good policy starts with accurate data. We need to know how much money is being spent and how it is being spent, and this includes total spending on drugs, including rebates. Second, our healthcare system is built on private markets, and we must do what we can to foster market dynamics that generate value. Although this is primarily a federal issue, one thing that we can do to improve competition is to streamline and improve the process for approving generic and biosimilar drugs. Our third recommendation is focused on a pair of complementary fact patterns. On the one hand, there are situations where there are multiple competing drugs that are similarly effective. The likely effectiveness of these drugs for a particular patient is well known and fairly predictable. Here, market participants can rely on established tools to improve value and competition. These tools include formulary structure and drug exclusions. Plans should keep doing this where appropriate. But, as we see in our MS case study, there are other fact patterns where patients and prescribers need access to substantially all drugs in a class. They do not know which drugs will work best for particular patients, and in these cases, existing approaches are not effective. As new and innovative drugs come to market, and we move toward more personalized medications, we should be discussing how best to drive spending, investment, and research to increase patient value. To achieve this increased value, at minimum, we need more transparency and better measurement of the comparative efficacy of different drugs. This concludes our presentation, and we'd be happy to answer any questions.
Well, thank you very much. This was really an excellent, and you really touched on some of the main issues. We began the discussion of prescription drugs yesterday, and there was one question I didn't ask, but I will ask you, since you've been looking at this, which is the increasing use of off-label use and how it is sort of confusing and confounding, even what we think of as understanding, how drugs work and have you guys looked at that at all?
We haven't looked at off-label use in that way or in particular, and not sure how good the data is or really how we would go about that, but we haven't.
Might be an area that we jointly ought to look at, because my understanding is that it's becoming much bigger. I know the pharmaceutical companies want the ability to even advertise these off-label uses if they're in certain journals. And, in and of itself, I'm not necessarily opposed to it, but the question is whether it really distorts the market even more than it's already distorted. So maybe we'll look into it. I don't know if Lauren?
Thank you for this presentation. I'm going back to slide 4. I'm looking at kind of the trends amongst the plans. Is there anything that we could learn or extract from some of the plans that showed significant decrease in spending from in 2014, 2015? So specifically looking at Plan 4, without kind of going into which plan it is there anything that we can extract about the way that they're contracting that led to that sharp decline?
So we don't know, we didn't dive down beneath these aggregate numbers in terms of each plan. Obviously, there are quite variation in the trend year over year, but these are, although these are per member per month, this involves the entire, this is spending for all of their utilization, all of their pharmacy spending. So it may relate to better prices that a particular plan is getting, but it may also relate to a difference in the number of prescriptions per patient, or in a shift of utilization between high-cost, high-priced drugs to lower-cost drugs, that sort of thing. So we haven't, there are lots of potential explanations for that, and we didn't explore more deeply to try to understand those differences in the plans.
Don?
Yeah, 2 questions, please. Can you explain in 6th grade level language what a rebate is, how it works?
Sure. So try to do this as layman's term as possible. Effectively, when I or you or anyone goes to the local pharmacy to fill a prescription, right, you pay a copay, $5 or $10, and the difference between that and assume the drug is $100. So if you pay $10, the $90 is paid to the pharmacy by your insurance company, right? So that's $100. So now the insurance company has paid $90, you've paid $10. There's been a total of $100 paid. That's passed back from the pharmacy up through the system of the manufacturer. At the end of the year, or quarterly, sometimes annually, the manufacturer will look at, or usually the plans and sometimes the PBMs will report back to the manufacturers under agreements they have and say, hey, we paid for X number, hundreds or thousands or millions of prescriptions for your drug. Give us some percentage of that back. So they've negotiated, 5, 10, 15, 20% to get back at the end of the year in the form of a check. So they'll get a check quarterly or annually from the manufacturer based on usually, in some respects, the utilization and other factors that that are in the contract, the rebate agreement. So that $10 or that $100 in my example, if the rebate is 12%, they'll get a check for $12, and then they effectively pay, $88.
So who gets the money?
So the money goes depending on who has the contract, right? In our example, some of the contracts are with the PBMs, so they get the money. But other health plans, 2 of the 5 we examined, the health plans directly have contracts with the manufacturers, so they're getting the money directly.
And if I were a pharmaceutical company and knew that in advance, what's to stop me from just raising the price of my drug to cover to compensate for what I'm gonna have to get back later for rebates?
Sure, I mean, that obviously happens. The manufacturer is the one entering the contract with the PBM or plan, so they know what the rebate is, and they obviously set the list price. Often, the rebates are keyed to the list price as a percentage of list, so when the list price goes up, the rebate will go up a little bit too. And there have been some sort of innovative contracting structures we've seen, they've been publicly reported, where some of the plans and PBMs are building sort of inflation protection, they call it, into their contracts. So if the list price goes up, can't go up more than a certain percentage per year, and if it goes beyond that, then the rebate percentage will go up as well.
And one last question. Is drug reimportation from other countries an option for the state to approve?
It's not something we've looked at specifically, at least in regard to this examination. I know from other experience that there are federal regulations involved there as well. So that's something that we have to consider.
David?
I just want to pick up on Don's last point. What are the options for any particular state in addressing this? So if I look at your recommendations, there are some about transparency, which the state could follow up the report that you've done by more regularly and accurately reporting these. But then the other action recommendations seem to involve federal action. And I guess I'm wondering, is there something in between? Like, I know California is debating a pharmaceutical bill. What could the state think about?
David, if I might try and take a first stab.
Please.
And turn it to the team. One thing that we were kicking around in our office when we were doing this report is it's really a first-year report. It's our first time issuing subpoenas, doing a deep dive into this particular area. So for a lot of us, it wasn't as satisfying as, thinking about where we might be in a subsequent year. I think where we settled, focusing on tools in our own backyard, as the Senate President said, it does start with more information and transparency. We really are, in my opinion, much less further along in this space of total medical expenditure than we are on the medical side in terms of standardized, routinized information that's released into the market to, let 1,000 flowers bloom, to drive activity by, any number of stakeholders. So without pretending that that's sort of sufficient or a silver bullet, a lot of the legislation that you're familiar with and that the Senate President has introduced in past years focuses on better quantifying and getting that data in a routinized fashion, because it can feed into any number of initiatives, and that's why we started there. From there, it could build into recommendations 3 and 4, which have to do with measuring comparative effectiveness. And you can't do that without the first piece. But with that latter piece, it would, depending on sort of stakeholder interest, allow for more innovation in contracting practices like value-based contracting.
Kim?
Yeah, thanks. Just returning back to the rebate question for a second. I think I heard you say that, and it plays out in the data a little bit, that the rebates did have an effect of reducing the overall cost. And just in the 2014 trend, it seems like it was more effective across all pharmaceutical spending and less effective for a specialty drug spending. And I wonder if you have a reason for that, or is there why that might be?
No, again, we didn't look sort of below these aggregate data at any particular classes aside from MS. So, I think it's not clear.
And, yeah, I would just add, in the 2014-15 trend for specialty, the rebates did grow significantly. So I think there is some element of stakeholders maybe negotiating more aggressively to get larger rebates as specialty drug prices have increased.
And Tim, I think both your question and Lauren's are terrific ones. Once you have these types of patterns in front of you, once you have the data to be able to see this, to sort of dive down, because I take your question, Lauren, as, you did look at different contracting approaches. So was there any pattern that meaningfully led to, differences among plans? And some of that does get into confidential information. But this forum could sort of debate whether more transparency in that area would allow us to come up and be able to identify which approaches are being more effective.
And Karen, what would be really interesting, I think, on that slide 4 chart, if you're able to do it, would be to go back and take out of the 2014 trend all of the Hep C drugs, because one sort of semi-obvious reason for the differential between the 2013-2014 trend and the more recent trend is that's really when the Hep C drugs were introduced. That is dramatic, and it was a good question, but it would be really interesting to see those same data absent that kind of one aberration.
Yeah, that's a great point, and really helpful. And something that we've been sort of kicking around is, as we want to meet the future as a Commonwealth, and as the AG described, there's great expectations and hope placed in the further development in this area, sort of thinking ahead to the next breakthrough drug and the next Hep C, and how that will both affect trend, but also how that will how we want to think about access and cost with respect to that breakthrough.
Ron, I'll give you the last question.
Great job on the report. One question that I have in looking at the price increases from 2011 to 2015, they went up by some 66% over that period of time. Did you look at any reasoning, because the same drugs, right? Why you would have that type of cost increase on those specific drugs? Did one drug have more of an impact than the others? Why such an increase on the same drugs?
We didn't really look into the reasons why the drugs increased, just the fact that they did. It was pretty uniform across the suite of 10 drugs. It wasn't driven by increases in one or two drugs.
Did you find that surprising, that it was so consistent?
We did, yes.
Well, I want to thank you. And Karen, as I understand what you just said, this is the beginning of a more detailed discussion. And I know we look forward to working with your staff and having you come back next year. And as David Cutler pointed out, this is an area of intense interest all around the country. And we're very, as the Senate President said, we need to be looking at other states, to what extent they're doing things. Obviously, it's an important area. It's important for our economy in terms of the drug industry, but it's also it's the main growth area for our spending, so we can't ignore it. So thank you very much. This was great. Thank you.
Thank you.
Good morning. Turning from pharmacy to another important healthcare cost factor, one that is often overlooked, is the social determinants of health. So it's my privilege this morning to introduce Lauren Taylor. Ms. Taylor co-authored the book, The American Healthcare Paradox, which has been featured in media outlets including the New York Times, MSNBC, and C-SPAN. She has published peer-reviewed articles on global health and the relationship between health and social services. She has worked at both Harvard and Yale's Global Health Institutes and Harvard Law School's Center for Health Law Policy and Technology. Of course, she must have started this all when she was 5. Her work provides us with a robust evidence base that investments in social determinants of health not only improve health outcomes, but also reduce healthcare expenditures. Savings can be so significant as to offset their cost. Every dollar spent on housing can yield up to a 6-fold reduction in medical spending. Medicaid agencies, this is one I'm particularly interested in, Medicaid agencies realize savings that are nearly double the cost of nutritional assistance programs. Some efficiencies accrue due to reduced utilization of high-intensity care. And patients receiving integrated behavioral medical services are less likely to visit the emergency department or be hospitalized, lessons important for Massachusetts. Our healthcare system continues to not holistically address social behavioral medical influences on patient outcomes. The Commonwealth actually has been making some efforts in this area, but we're very appreciative that Ms. Taylor has joined us this morning to set the stage and remind us of the importance of this issue. Good morning. Thank you.
Good morning. Thank you so much, Commissioner, and good morning to everyone here. In part, I feel thrilled to be here, and in part, I feel like I have nothing left to say between your comments and, my goodness, to hear a health economist talk about the value of social services made my heart sing this morning. So I've been fighting for that a long time, and here we are. So my goal is to kind of give an overview of really what I know and what I've learned over the past 5 years thinking and working in this space. And so, of course, I felt a little overwhelmed when I started this, and so I thought, always go back to the assignment, right? So I went back to what we're trying to do today, and that is to examine the drivers of health costs, including particular challenges and opportunities. So I said, okay, great. I've got 40 minutes. I think I'm going to try and take 25 of that and leave 15 for discussion with you all. But kind of the overview would be, first we'll talk about a driver, and I'm very particular about that article. It's a driver. It may not be the only driver or the biggest driver, and in fact, it's very hard, I think, to know the relative proportionality of what's driving the cost. Is it pharma prices versus unmet social need? But I think unmet social need has for a long time been one that we weren't even talking about in the conversation, and so that's part of what I'm going to try and do here. Identify what is the evidence for even thinking that unmet social need is really a driver. And then an opportunity would be kind of social service investment, and there are all sorts of flavors for that in terms of Medicaid waivers, state investment, and then all sorts of really interesting firm organizational level behavior, even some private groups that are springing up to do some interesting configurations around health and social service integration. And then at the end, I thought I would pull out 2 particular challenges that I see really at the front lines. This is starting to sink in for practitioners and for people who are running health systems, and so they're doing their own levels of experimentation. And I think they're really running into 2 big challenges that I can highlight for you all so that we can collectively think through whether or not there are policy solutions to this. So that's the goal. So this is the chart that kind of launched me into a deep dive into social services, right? It's the one that we've all seen before, and it's percent of GDP spent on health services at the national level for all of the OECD countries. So on the x-axis, you've got 32 of the 34 OECD countries, and of course the US is huge, we're at 18%. This is data from 2009. We can speculate as to why that number hasn't changed very much until now, but we're still right around 18%. And yet, as people have already alluded to today, we know that we don't necessarily get great health outcomes, right? There are some bright spots. You know, if you want a knee replacement, we can do those quickly and we can do them well if you're an insured person. But if you're looking at the big population health level outcomes that we generally talk about in schools of public health, which is where I started my career, we look lousy. So we've got 34 OECD countries. If you want to talk about maternal mortality, we rank 25th. If you want to talk about infant mortality, we're 26th. If you want to talk about low birth weight infants, we're 28th. So for 18%, the highest spender by so much, we would want to at least see that we were like in the top half. and we are really fledgling when you look at these outcomes. And so that's what initially started this inquiry that was really done in collaboration with Elizabeth Bradley at Yale. We said, okay, so this is the paradox, right? This is where the book title came from. Huge health spending, not great health outcomes. How could we kind of try and reconcile this? And so as public health people, you know, there's always a department in public health schools that are something to the effect of social and behavioral sciences, right? And so in a public health school, it's natural to think about, well, what really does drive your health? It's become kind of almost trite to now trot out this statistic, but it's generally 60% social, behavioral, environmental factors. It's rarely more than 10 or 20% in the studies that are available to us really attributed to healthcare, your access and quality. And so we said, okay, well, where is that accounted for in this analysis? When we're always looking at this graph and scratching our head and saying, what can we do differently around healthcare? Well, maybe what we can do differently is not in healthcare at all. It's about these other factors that have historically not even been represented in the analyses. So when we looked at the OECD data, we were fortunate that they had a nice column that we could add into this analysis that was spending on social services. And so what that counts is kind of a national investment in nutrition programs, housing assistance, job training, the traditional trappings of a welfare state, if you will. And so we said, well, wouldn't it be interesting to kind of put that in and see how that changes the analysis? And so this slide gives you a sense of how that changes the analysis. Here, again, you've got your OECD countries on the x-axis. Your blue bars are still your percent of GDP spent on healthcare, and your orange bars are percent of GDP spent on social services. And so what you see is that the US comes into a more middling position, right? We're no longer the gargantuan high spender, but there is something that is once again unique about the US, and keen observers may have already noted, we're one of the only countries in the set that has a bigger blue bar than we have an orange bar, right? And so what we did next was we said, well, that's kind of interesting. What if we took a ratio of social service spending to health service spending? And so when you take that ratio, actually the US has the smallest ratio in the whole data set. And to summarize the data in a way that's not presented in the slides, essentially for every dollar spent on healthcare in the US, that's matched by about an additional 90 cents in social services. And for the hypothetical OECD country, every $1 spent in healthcare is matched by $2 in social service investment. So it's a really flipped allocation pattern that we're seeing in the OECD. Of course, it's not enough just to find cool patterns in the data. You've got to show that they're somehow meaningful in predicting some kind of health outcome. And so that was really the goal of this initial paper back in 2011 that said, actually, this ratio that we've now created is not only predictive of a range of health outcomes, but it's more predictive than your healthcare spending alone. And this was true even when the US was excluded from the analysis, which was important because, you know, we often think the US is kind of driving these trends, but here it's not. And so this was kind of a big deal for us, and I think in some ways it's what launched the book and a whole stream of research that I can go into. But it was the first time I think that people said, wow, maybe kind of we've been too narrow in our accounting about what kind of investments a country makes or should be making as it pursues health on a population level. So the next question, of course, has always been, there's an exceptionalist in every room who doesn't like the fact that we were comparing the US to European countries. And so they would say, you know, tell us about inside the US, Lauren. And so the team that I worked with at Yale, again led by Betsy Bradley, was able to essentially recreate the same analysis at the state level. And so what you see here on the slide is a heat map of the US that shows the social to healthcare spending ratio at the state level, where your kind of Kelly green or emerald green are those states that most strongly prioritize your social service spending relative to your health service spending. And your red are those who most rely on healthcare spending. Unfortunately, I think this heat map looks a lot like virtually every other heat map we see in health services research or public health of the United States. You've got a kind of Pacific Northwest that's looking quite good, to use normative language, and you've got kind of the Bible Belt area of the country that again looks to be struggling. I would say Massachusetts comes up orange. It's near the bottom. And I think that gives me an opportunity to highlight that ratios are just tricky metrics to work with, right? Because you've got a numerator, which is your social service spending, and you've got a denominator, which is your health service spending. And so in the Commonwealth, even though we like to think of ourselves as quite generous on the social service side, our health service spend is actually so fat that it's almost the case that no matter what we did in the numerator, we wouldn't be able to look like a high ratio social service to health service spending compared to the other 50 states. So that's a little bit of insight on Massachusetts in case that's where your eye went. But I would say the heat map, looking like every other heat map we've seen, raises a really important cautionary point about all this research, and I like to be humble about what it can and can't do. It raises this question of what drives what, right? And can we say for sure that it's the ratio that creates or causes the health outcomes? And I want to be very clear that we can't. These are descriptive studies, and so we can say that this ratio is very correlated with a whole range of health outcomes, but it's very difficult to say if it is the case that more social service investment from a state creates better health outcomes, and therefore people who are healthier have to consume less healthcare spending, or it's the other way around, you know. And in fact, I think reasonable people would probably have to agree that it's probably both, right? And there's a vicious cycle happening here where when you have an unhealthy population, they're consuming a lot of healthcare resources. For a state that can't run a budget deficit, that probably means crowding out other kinds of resources on social services. And so less social service investment therefore just begets potentially a more unhealthy population. And so I think that's part of what makes this a really pernicious problem, is that you kind of get caught in this cycle of healthcare robbing resources from other state budget lines, and that unfortunately only increases the risk to the population that they will be unwell. So again, this is the ratio. This is how it stacks up in the 50 states. It doesn't really matter unless you can show that it predicts something important. And so this is the publication that just came out in Health Affairs in May of 2016, showing that once again, this ratio is actually quite predictive. And I would say we were able to do it on a whole bunch of different outcomes that we had not been able to test in the OECD, things that we thought really would not necessarily come up as associated with the ratio because we thought they would be highly sensitive to medical investment, like lung cancer mortality. We thought, we'll try it, but no confidence that it would come out significant, and it did. So I think it was good validation that this ratio had even more predictive power than we thought it did. I would also just say, for those who are interested, the original OECD analysis has also been replicated by RAND, which was really exciting. So it's a whole concept that has really kind of gained some traction in the research literature. So next, people ask great questions, and the next logical one, of course, is, okay, Lauren, so you've been talking about this orange bar that is investment in social services, but can we be more precise? Like, which social services are you really referring to? And there was not a great way to do that empirically, to try and figure out which type of social service was really driving the health outcomes. But what we did instead was commit to a really large literature review that was funded by the Blue Cross Blue Shield Foundation here in Massachusetts. And the question we asked was, which social services, according to the literature, both produce better health and save healthcare dollars? And I would just note that that's a very high bar, right? Because there aren't many healthcare investments we could point to that would save healthcare dollars and improve health. You know, vaccines come to mind, but apart from that, most things cost money. And so these are things that really do, according to the literature, save healthcare dollars and improve health. And there were really kind of three buckets that came out as the most evidence-based. I would not say any of these are foolproof. I would be happy to debate the merits of these literatures, but these are the ones that have the strongest evidence base. Far and away, it's housing. Housing has an incredible evidence base, a lot of randomized control trials, many of which have been run here in Boston. Housing seems to be, if I had to put my money on something, housing is the winner. The next one is nutrition. Nutrition has a really strong evidence base. There's all sorts of different shapes and sizes to nutrition programs, of course. One that's very strong in terms of the evidence is the WIC program, Women, Infants, and Children. It's been tested again and again in terms of cost effectiveness and comes out more or less smelling like a rose. And then you've got home delivered meals for older Americans, which I always like to pause on because I think that's a really interesting intervention. We've put it here under nutrition, but really I think it's a dual intervention. On one hand, you've got a meal showing up at an older American's house, but on the other, you also have a person, right? And so I think in an age where we're really struggling to confront social isolation as a very potentially damaging social determinant of health, I think this is kind of a twofer. The last one is case management, and the case management literature is, as many of you probably know, vast and kind of difficult to wrap your brain around. I'm still not sure that I've done it by any means, but I do think that the studies of case managers that consistently seem to impress in terms of their data are those that have a home visitation component. And again, I think there's something to that home visitation that there's a social bond there, there's a kind of therapeutic relationship that really makes a difference as opposed to someone who kind of shuttles you between rooms in a hospital. All of this literature highlights kind of what some people have called the wrong pocket problem, but economists would more traditionally think about as externalities. And that is that potentially we've forever underinvested in these things, our social services, because we've failed to appreciate the returns they create to the healthcare system. And so that's something I think to keep an eye on in all of our policy thinking about how to make sure that when we make a social service investment or a social service agency makes an investment, that if that actually creates better health, somehow that group needs to be rewarded, and we can't allow healthcare to just continually capture kind of the returns on the investments made in the social service industry, unless we're going to fully blend those two, and it's one bucket of money. But if it's going to be two buckets of money, the people making the investment need to be the ones who, in some way, are recouping it. I would just note briefly, when we're thinking about the trade-offs and the interaction between health service investment and social service investment, this is data pulled from a really good paper that I think is really underattended to. It's by McCullough, and it's called America's Healthcare Dividend, or Healthcare Dividend for America. It's a group of researchers out of UCLA, and they go through a painstaking process of saying, okay, if we take seriously the IOM suggestion that around a quarter of healthcare spending is waste, that delivers us to a dollar number of about $337 billion. What could we do with that $337 billion if we were to put it towards different social services? Or just, they don't even call it social services, right? That's my language. They say other investments in health. And it's staggering. I mean, these numbers don't quite give you a sense of just how lengthy the list is of things we could fund, but $85 billion on education, just so you have a sense of what that could do. That could do universal preschool. All 24 million children in elementary school could go to a class size of between 13 and 15 from between 20 and 25. So a substantial reduction in class size. And the size of students, American students in Head Start could be doubled. And that's just in that $85 billion on education. There's still $37 billion on child health, $23 billion in infrastructure, and they basically get through this whole list and say, we still have $168 billion left over. What do we do with it? We could put it to debt reduction. So it's a really impressive paper, and it just gives you a sense of the magnitude of what the trade-off is here at the national level. At the state level, of course, this is a graph that suggests more than just a trade-off, but actually some evidence of crowd out. So this is a graph that I'm sure you've seen before. It's from the 2014 Cost Trends Report. And we're talking about between 2004 and 2014, a 21% increase in state spending on health. And again, I would just reiterate, because I think some people don't know, at the state level, there's no capacity to run a deficit. And so when we're talking about a marginal dollar, we're really talking about a marginal dollar. If it goes into health, it cannot go into something else. And so this graph suggests overall a 7% decline in these other investments in health. Of course, again, I want to caution us to say there's no way for us to know for sure that, the increase in health is exactly driving this trend, but to my eye, it's very suggestive and very concordant with the overall narrative. So now we get to kind of opportunities and challenges. I would say I made this slide a few days ago, and I realized that you all have plenty of people on hand to talk to you about innovative Medicaid redesigns. But generally, I think what's happening across the country is that these redesign efforts are trying to be innovative in terms of including community-based organizations and braiding funding streams together that can address the social determinants of health. They're running into all sorts of walls and fighting with CMS, particularly around the issue of housing. So Oregon and California have both made housing kind of their social determinant of health of choice that they are really going to go after. Unsurprisingly, probably given what I've told you about the evidence base there, it's the sturdiest evidence base for people committed to evidence-based medicine to stand on. And they're basically duking it out with CMS to try and figure out whether or not Medicaid dollars can actually be used to pay for rent versus just kind of the wraparound supportive housing services that traditionally go into a supportive housing setup. New York also has a very interesting experiment underway, and their real focus was on community-based organizations, CBOs. They were very aspirational about the role that CBOs could play in doing healthcare delivery and really working with the health system. I think they've found it much more difficult than they thought it was going to be to really get to a point where health service organizations and community-based organizations could contract with one another for services and go in on joint delivery of services, and I'm happy to come back to that. Now, if we go from the state level to kind of the organizational level or the firm level, I would just point out this is the kind of really, I think, shocking and innovative work that's coming out of some health systems. So this is from the New York Times, of course. It's just a few weeks ago. And this was the Maine CCO, which is Oregon's version of an accountable care organization. 6 health systems, Kaiser, Oregon Health Sciences University, a few others, went in and jointly made a $21.5 million investment in housing stock in Portland. And I have to say, that number surprised even me. I don't think, it's not yet clear exactly what budget line this money is coming from. But I have to say, I don't think OHSU and the folks there were people that we profiled in the book years ago for what was already pretty innovative work around social determinants of health. But I would say I don't think that this is a purely altruistic investment. When we were there, we were already seeing them thinking very strategically about, yeah, we want to reduce utilization among Medicaid clients. And if you asked enough times why, it was, it's going to open beds for other high-paying clients to come in. So, you know, we can think what we want about that, whether that's good, bad, or indifferent, but I mention it just because I think these folks have a vision of how this money is going to come back to them. It's not that suddenly they are seeing themselves as a local philanthropy. I would just mention briefly, there's evidence for all sorts of integration models, and this slide is one that I use to kind of think left to right about lightest to heaviest lift in terms of integrating health and social services. If you think about what's most germane, you could think about community benefit grants that are already ongoing here in the Commonwealth and everywhere else. Nonprofit hospitals have to kind of kick some money out the door. And so they do that often by making grants to local communities. And so there is some scaffolding there to start to think about how we could strengthen those relationships or make them more kind of mutually accountable or more meaningful, scale them up. Some healthcare organizations are offering individual social services. You'll hear from Kate Walsh shortly. BMC has had a food pantry on site for a very long time, and I think that is only going to increase, especially here in Massachusetts, as we see the growth of Medicaid ACOs, and suddenly these large institutions are going to have responsibility in a total cost of care way for Medicaid clients. You can already kind of start to see the wheels turning around how they're going to supply those, and do they build those new capabilities in-house? I suspect that many will. Programmatic partnerships can take 1,000 flavors and forms, but what would come to mind here are things like medical legal partnerships, which were also born at BMC. Out in Gloucester, Mass, you can think about the kind of relationship between the police department and a local hospital trying to really work hard on opioid abuse as another form of programmatic partnership. And even within that, you know, you could blow out another continuum in terms of the formality or informality of the contract. Sometimes they're very formal, sometimes they're less formal, sometimes it's pay for performance, sometimes it's just kind of a block grant. A lot of variation and not well studied. And then you've got some strategic investments like the one that I just mentioned from Portland. And I would mention, I think, kind of the holy grail here, in my eyes, is really pooled health and social service budgets in some way. Maybe not at the state level, but any time that we can really give tremendous flexibility to a group of people who know a local community well, to kind of be creative about where they want to put the dollars, I think that's where we're trying to get to. Interestingly, in the US, the VA is a good example of this because, you know, they do benefits and of course they do the healthcare. And so in our book, and since then I've followed some really innovative work at the VA. VA has plenty of challenges too, but I think they're doing some very innovative stuff here because as a single payer on both sides, you don't have the wrong pocket problem. If you make investments on the benefit side, the social service side, that comes back to you in reduced healthcare utilization. So I'll just end with two conceptual challenges as I see it. And one is really just about governance. So there's this huge question that as you think about healthcare contracting with a range of social services and you kind of scale that up in your brain, you think about the most progressive healthcare organization we could imagine, a BMC or something like it, you start to get into this challenge about, okay, well, who's leading? And so if you have a hub and spoke model, just as a very simple mental model to work with, the question is healthcare at the hub or is someone else at the hub? And I think there are arguments on both sides, but I think it's something that every community needs to be clear on. I personally don't think we have evidence enough to say who should be at the center, and I personally don't care who's at the center. All I care about is that within a geographic catchment area, however we define that, everyone at the table seems to know who's leading, who's following, and the role definition is as clear as it can get. An argument for putting healthcare at the center would be they've already got the money, they've got huge managerial capacity, they've got expertise in like responding to incentive systems that we've seen time and time again. Others will say, don't put healthcare at the middle. If you put healthcare at the hub, they will totally medicalize the vision, and that's a tremendously dangerous place to put them. Plus, we know that there's enormous waste in that system. Why would we put them at the middle? But if you don't want to put them at the middle, you're left with this power vacuum, if you will, of who sits at the center and who kind of coordinates these contracts and coordinates the disparate actors who need to be involved, as we've just shown. Some communities are working with local place-based foundations who will take on this role. In some cases, a public health department will take on this role. But this is something that I think researchers are actively looking at. It's tough to do rigorous research even because each community is different and it's hard to know like what's a control versus an experimental, but we are watching it. I think it's a really key open question. And the last set of challenges I would say is within the hub and spoke, if you just think about the actual relationships between healthcare and social services, I started to go down this path when I mentioned New York's challenges with their Medicaid reform. I think it's much more complicated than we initially gave it credit for to really think about contracting between health and social services or making formal relationships. Here are just 3 questions that come up all the time. For a large healthcare institution, do we make these services in-house or do we buy or contract them from the community? This is kind of a classic organizational theory question, make or buy. But I think it also is coming to have kind of normative and ethical value implications to it as the state considers, okay, if healthcare make all these services in-house, what does that do to the existing community-based organization ecosystem or infrastructure? As a healthcare organization, how do we vet potential partners? If you're in Boston, there's 20 food pantries. You don't have great financial visibility into them. It's very unclear at some times. Are they going to be here in 2 years? How many referrals would be enough to be incentivizing but not put them out of business? You know, because there's a real risk that if you open the floodgates on these referrals, small community-based organizations may not have the capacity to really take them on. And then how to share information with partner organizations. This gets to the heart of HIPAA concerns. We want to do integrated care and we want people to be on the same page about what a patient needs, and yet there's all sorts of concerns, particularly from the healthcare side, about whether or not you can really share the information that you want to share with non-medical personnel. And with that, I'm going to pause because I'm sure you have questions. Thanks so much.
Thank you very much for your presentation. So I have one quibble, and that is on the chart, which I actually have, every time it comes up, I take exception to, which is the crowd out.
Yeah.
Because Medicaid is the only insurer that pays for not just acute care services, but long-term services and supports.
Mhm.
And $5 billion of the $16 billion Massachusetts Mass Health Program pays for what I would call social determinants of health. Group adult foster care, personal care attendant services, home health, day HAP services are all paid for out of Medicaid, and that I would say actually changes this. So, and again, it doesn't change the conversation, but it does change. I actually think if you were to pull out the long-term, I was looking at the heat map on some of the states that are in the lower quadtile there. Actually, if you looked at their long-term services supports, they actually are. So what I would call social determinants of spending. But having said that, so I just, because every time people start comparing Medicaid with Medicare and other things, I sort of sit there, yes, but Medicaid pays for other things that healthcare doesn't pay for. I'd love you to talk a little bit more about the hub and spoke, if you will, because as I'm sure you know, or I assume you know, since you put Massachusetts as one of the potential innovative states, is the question of how do you bridge vertically organized institutions and community-based programs that are much more horizontal around addressing the holistic health needs of patients. And one of the things in the Massachusetts waiver I feel like I'm giving birth to a $1.8 billion baby any moment, is, I know, in fact trying to take the DSRIP dollars and not have them solely go through the accountable care organizations, but to allow for different, and I don't want to use the word experiments, but different investments to try to bring them together.
Yeah.
So I would welcome your thoughts on that.
Sure. So in relation to this question about Medicaid ACOs in Massachusetts in particular, I think there have been two hub and spoke concepts kind of floating around. One is the Medicaid ACO as a hub and spoke, of course, so you'll have whoever your pilot ACOs are first at the hub, and they're going to, let me step back. There are two versions of even a hub and spoke model with healthcare at the center. There's one in which the organizational boundary, the healthcare organizational boundary is just around the hub, and then it contracts with community-based organizations and behavioral health providers who are their own firms, and so you're contracting inter-firm. That kind of preserves some flexibility and autonomy on the part of the community-based organization. So that's one that I kind of showed and is more common. The other one is thought experiment. If someone like I won't name names, if a large health system decides that they want to build all of these things in-house because they've either had poor experiences with other vendors in the past, or they believe they are a brand kind of predicated on excellence and no one will be able to deliver services with the accountability that they want, then you start to think about a hub and spoke model where you've got kind of medical care and then housing, nutrition, behavioral health, home health, all as spokes, but it's all within a large organizational boundary and they kind of become like the Walmart of healthcare. And so those are two different visions of the future that I think we can and should potentially be clear on. I think you're going to have variation even within Boston on how that goes, with maybe a BMC who has longstanding relationships with the community saying there's no way we could start to build these things in-house because it would be terrible for our reputation. It would be seen as competitive with partners we've had for a long time. Other institutions may not feel that way, and in fact may feel very earnestly that they are doing what's in the interest of the patient by building these things in-house because they have such kind of managerial expertise. People in the community generally tend to disagree and say the learning curve for coming up to speed on how to provide nutrition or how to provide housing is just too steep. You'll never get there in time. But I think that's the debate that's kind of going on right now. The other hub that's being talked about is, I don't know, I imagine you saw this as a social service hub of sorts. And so this is another interesting idea that goes straight to the challenge of contracting. Some people have said it's totally unrealistic to ask Medicaid ACOs or any ACOs to individually go out and contract with a whole bunch of social services. Could we not create some kind of infrastructure at the state level that said, like, this is a warehouse of social services? You go to one place as a healthcare organization and say, I want to contract for 25,000 visits to a food pantry and 15 beds in a homeless shelter, these things, here's my list. And then kind of someone who is a front for the whole social service industry or community-based organization industry then goes and builds the contracts and kind of just delivers the contracts to the healthcare organization. I know that was floated in public comment. I haven't heard anything else, but I think it's an interesting idea to hear people talk about that because it's empathetic to the point of view that contracting is more difficult than we maybe think, and even just learning the landscape of available community-based organizations and resources is a lot to ask. I want them to do it, but I'm always careful to be empathetic to the fact that it is a large ask.
Lauren, rarely have I heard a presentation that has had more of an impact, at least on my thinking. You were so generous back in Princeton in last May, and I'm here to apologize that I've been stealing your slides ever since. The only thing I can say is, if you tell me the charity of your choice, I will make a contribution. All right, so the one area that I'm really having a hard time though, and I mean, I would like you to think more about it because I've never seen anybody think so clearly as the way you think. I'm having a hard time with the ratio. I just don't know what, and you laid it out perfectly here. I'm really having a hard time. So you take a state like Massachusetts, which is at the top of the list when it comes to spending. Maybe some of us believe maybe we spend a little too much, and we could reallocate it a little differently. But for us to be penalized in a way to a state that's spending very little on health care and actually looks better on the ratio, You know, we spent $1,000 on healthcare and $800 on social services. They spent $1 and $1.25. I mean, I think this is your area, and you've been so insightful as I listened. Think harder about that ratio, and maybe it needs to be modified in a way. I'm not saying it doesn't lead to some good things that you laid out, but thank you so much. I think you and your team are changing the thought process going on more than anybody else I've heard about, so thank you.
Thank you so much. If I could just respond briefly to the ratio issue, I think it has issues too. It is by no means a perfect measure, and I feel so strongly about that actually at one point we were contacted by RWJ who was excited, and someone generously was like, I want to try and think about putting the ratio into the county health rankings. And that was the point at which we said, I just don't know if that's that useful. You know, it's a proxy measure. I think, frankly, it's going to have been a flash in the pan. I don't think that this is a measure we're going to be tracking for 10,
Good.
20 years, in part because, as you know, the secretary said, we're shoving more and more social determinants of health work into healthcare now. So even in 5 years, I'm not sure it would be comparing apples to apples to then say, well, the ratio in 2020 is this, and in 2015 is this. It would be measuring different things. So I take that feedback really seriously, and I would just say, you know, I try to be as humble as anyone about the fact that it has limited use. It's a proxy, it's a signal about something in terms of how we allocate our attention, even more so than our investment or our resources. But, you know, after that, we need to take this conversation someplace else.
Lauren, I spent a lot of my career working with states, trying to teach them how to use Medicaid to pay for social services. So as I look at the sort of ratios, I'm wondering to what extent, picking up on Mary Lou's point, to what extent that's been taken into consideration in looking at the difference between health and social service expenditures.
Yeah, not in any particularly systematic way. You know, I would be interested, though, perhaps we can talk later about how much spending on Medicaid you think really gets to social services. My sense is it's always been a fight for people like you to kind of do wraparound things that are of a medical nature but in a social setting. So we talked about it and we didn't go over the top trying to build in controls. It was a huge data lift to begin with, just to try and, you can imagine, figure out how is hospice considered health or social in Texas versus Connecticut versus, so we were limited in what we could do, but again, I take the critique seriously.
Dr. Cutler?
First, I want to start off by noting that, in fact, when Lauren was 5 years old, she was admitted to the PhD program that I now administer, which technically means I deserve some credit for this, but also the right to ask for revisions to her PhD dissertation.
Bring it on.
So I would like to ask for an extension to chapter 17, and that would be a one-page chart showing for each of the 3 areas you mentioned, housing and homelessness, WIC and food programs, and case management. What is Massachusetts doing, and what are the best states doing? Or the best, they don't have to be states, but best regions of states. So how far are we behind the curve, and what recommendations would you offer the Commonwealth in terms of, oh, okay, we should be doing this, we're doing actually really well here, but here are a few areas we could do improvements, or we're actually quite behind the curve here. I think that would be a very important thing for us to be able to have, for the Commonwealth to be able to have.
Yeah. One thing that's top of mind that is not specifically around these 3 areas, but is around data infrastructure, there are other states who have a unified back end. So someone who has a Medicaid number in the system has the same number when they're collecting SNAP or TANF or a range of other social services. And I think that would be enormously helpful from a research perspective to be able to see how these two sectors and types of spending interact at the individual level. Washington has a really robust infrastructure, and I know that it's always a political battle because people are concerned about the surveillance aspects, potentially for good reason, because I think some of the predictive analytics they can do now are just frankly astounding. You know, if someone has been on food stamps for a long time and then they don't pick up food stamps or retrieve their food stamps for 3-4 weeks on end, they can predict with something like 80% certainty that you're either in jail, dead, or in a hospital, you know. So there's a lot you can do, and again, politically loaded, I wouldn't pretend to understand what the process is to get there, but I think that's a dream to hold out for the future, especially as someone in a doctoral program looking for research opportunities. That would be a treasure trove.
I'd be happy to have you add that to your list of things that we should do. in the
Dissertation committee today. Dr. Allen?
Madam Secretary, would you like to join the committee?
No.
Lauren, thank you for that presentation, which was absolutely sensational. And I have about a million questions, so I'll try to restrict myself. But I'll just ask two that are kind of interrelated. One is, as you just mentioned, we know that adverse childhood experiences end up causing adult diseases. So much of what we're paying for in healthcare now is the result of what happened to children decades ago or years ago. And so one question is there a particular, if you could invest in a certain age bracket, is there anybody you would prioritize? And my second part is about housing, which I also agree is probably the most important thing. And I wondered if you could comment on racial disparities around everything, but especially around housing, because I think it's a particular problem in that arena.
Yeah. So this is great. They're tough questions. Where would I place my emphasis in terms of populations to invest in? You know, I think this gets to the heart of how do we interpret the problem of social determinants of health? Do we think that it is and or should be framed as an everyman problem, meaning we all have social determinants of health. We all probably rely on medical care inappropriately in some instances to fix or attend to problems that are not medical at root. There is some evidence that suggests even in the US among white, employed, insured people, that bracket, that cohort, still performs less well on population health outcomes than similar cohorts in Europe. So there seems to be something just about being American and having this enormous kind of medical infrastructure available that is problematic. That's one way to think about social determinants of health, and it's we're all in it together and we all need to change our behavior. The other is call a spade a spade. This is really about kind of low-income, traditionally marginalized communities, overwhelmingly of color, and they are the ones most affected by adverse housing, you know, unclean water, not great air, all sorts of things. And I have to say, I feel compelled by both those arguments, and I think it's kind of a political decision about which way you frame it. Do you think that it's required for political expediency to be framed as an everyman problem, or do you think it's more important to call a spade and say there are some communities that are disproportionately affected, and we just need to say they need our help more than anyone? I think children would be a great place to start, although I would say the education literature is not as robust as we thought it was going to be. When we went and did that literature review, we thought, oh, education will come up huge in terms of the health returns of education investments. It didn't. There's some stuff, but it's not overwhelming. And I think part of that gets to a really key point about research and the extent to which we can expect there to be robust research on all these social services and the impacts to health. No one has ever thought about this before. We don't have an NIH that's funding gobs and gobs of research on social services, and so I'm always careful to say it's unfair to compare an investment in education and an investment in more MRI machines. There will always be more evidence available to us on MRIs than on education, even though we may think that education is the sounder investment. So children would be one population. I think the elderly are another, or older Americans is another, especially around kind of social isolation and the things we were talking about there. And then, of course, all sorts of communities of color. And it gets very dicey, I think, about how to link medical infrastructure or health systems with those communities, because there are long legacies of mistrust for good reasons. And, you know, you've got the formal contracting questions around how to link them, a community-based organization and health system, but then there's all sorts of informal stuff there about how you can broker a relationship premised on trust and equal division of resources and power. That is a whole nother stream of research that I'm really interested in, but we don't have good answers on how to do that yet.
Thanks. Dr. Borg.
Thanks, Secretary. This is brilliant, Lauren. Can I have your slides, or to get them from Stuart? So from the point of view of Massachusetts policy, I'd like, maybe you can't answer this, but where is the problem a linkage problem, where there are resources, they're really here, but we don't we don't sing together on the one hand, and where, if you were chairman, you were wondering where to put some extra money, you would say we don't have the resources and we have to build them. What do you think?
It's such a good question. We don't have a clear answer on it. My intuition is that in Boston, they're here, and it's a linkage problem. In the rest of the state, it may really be an investment problem. That being said, we don't have data, and I wish we did, on what is the current capacity of our social service sector in any of these domains. How many beds are there available? How many homeless shelter spots are there? How many, there's no sense of the capacity. And so I think that's another place that we could do a much better job, and it raises this question of, I wish we would build a clearer sense of collective consciousness about what we're really trying to do here, right? Because it's clear that we want to make the healthcare sector smaller. For some reason, I think for good reason actually, we think we can do that in part by retargeting people to social services if their core needs are really social in nature. But does that mean we're driving down health sector capacity and we're going to drive up social service sector capacity, and we should be trying to use Medicaid dollars or anything else to build the capacity of that system? Or do we think it's going to be like a worse before better? There's going to be a lot of shift from healthcare to social service, but then we think overall we should be trying to drive down that capacity or that load too. And so I think this is a high-level question for state policymakers to think about. What is the relationship we intend for these two sectors? And the only way to know that would be to have some better data on what's there.
Yeah, I'm wondering if that's an HPC agenda, potentially an asset map guided by what Lauren's telling us, where we would assess beyond just healthcare supply, what else is around and what's needed.
I would suggest that somebody take a look at what already exists. I actually would beg to differ that some of this data that you just cataloged is not available.
I've seen.
I would say it's not perhaps in the most one-stop shop, but I would say actually on number of homeless beds, number on addiction beds, number of residential beds, I think that data actually does. And they're actually in the Office of Child Advocate has actually done a mapping of social services for children's services.
It would be great for you all to take kind of a leadership role in getting that out there, because I've heard actually 1,000 people recommend, oh, we should make an asset map. We should make an asset map. And a lot of these maps unfortunately get created and then fall by the wayside
Or they get
without
dated.
without someone on the back end really kind of stewarding those maps in real time. So it would be great to see one map that had real authority and legitimacy to it.
We have time for about one more question, Mr. Chairman?
Great.
All right. Who would like to have the last question? Or we'll give you the last statement. How's that?
Oh, my.
There you go.
Well,
And first of all, thank you so very, very much. for
Again,
this
thank you very
presentation.
much. And
But we'll give you the last word here.
great. My last tidbit would be, I think there's already a lot of health and social service linkages happening in the state under the guise of the Prevention and Wellness Trust Fund, the Chart Hospital Program, things that you yourselves have kind of funded and provided real leadership on. To the extent that we can learn from those programs faster, I think we could make much sounder decisions, particularly around Medicaid and Medicaid ACOs, because the experiences are here, they're already with us. We just need to surface those learnings a little bit faster. I know that's hard for government, but if I could have a last word, that would be it.
thank you
Thanks.
so much. All right, we're going to take a 10-minute break. You were wonderful yesterday, and please be back in your seats in 10 minutes. Thank you.
A year and a half, and I always leave these hearings and the commission meetings thinking I didn't pay enough attention in economics classes. I did, however, study social and behavioral health, so I feel much more comfortable with this panel discussion. I'm going to ask each of our panelists to introduce themselves, tell a little bit about what they're doing in this space, and then we can open it up to questions from the commission. Kate?
Hi, good morning. Good morning, everyone. I think it's still morning. I'm Kate Walsh. I'm the president and CEO of Boston Medical Center. I'm very happy to be here representing BMC, which is the largest safety net delivery system in New England. We believe we have a long history in addressing our patients' social and behavioral health needs, and we know we have a very long way to go. We are a 496-bed academic medical center that delivers a full range of primary and specialty services with over 700 faculty who are employed by our hospital. We're very proud of our partnership with 14 community health centers through Boston Health Net. And finally, we operate Boston Medical Center Health Net Plan, which provides insurance coverage, peace of mind, and access to health care to over 225,000 members of the Mass Health Program and through the Connector. My big excitement and why I'm very happy to be here today with such an esteemed panel is the prospect of working with the Secretary of Health and Human Services and her team to put all of these services even more integrated together into an accountable care organization that we really believe will transform the care we're able to deliver to the patients we serve. So happy to be here. Won't take too much time because I've got a lot of people in front of us, but thank you again.
Thank you. My name is Toyin Ajayi. I'm the Chief Medical Officer at Commonwealth Care Alliance. I'm also really delighted to be here, particularly on this panel. Commonwealth Care Alliance is a Massachusetts-wide integrated health system. It's a payer as well as a provider. We care exclusively for folks who are dually eligible for Medicare and Medicaid through the Senior Care Options Program and our One Care program. We currently insure about 19,000 Massachusetts beneficiaries who are dually eligible, very significant burden of social determinants in addition to complex medical, social, and behavioral health needs. It's been our real honor and privilege to care for these folks and to learn how to build and sustain relationships with community-based providers that help us address the totality of their health needs. So really thrilled to be here. Happy to talk more specifically about what needs to happen from a policy perspective to enable these types of innovations and interventions to scale. But also to think about, and sort of following from Lauren's wonderful presentation, what the actual kind of global construct needs to look like, really to push us to move away from as compelling, I think, and as interesting for me as that hub and spoke model is, what you still have are silos. And it's just about how you arrange those silos. And so, really challenging us to think about how we can break down those silos and recognizing, as the Secretary has pointed out, that many of these services ultimately are provided for and paid for by the state and the Commonwealth in some way. How do we ensure that we break down those barriers so that we can actually bring them all together? And who's on first is kind of secondary to making sure everything's actually there to provide and to deliver for our beneficiaries. So looking forward to further conversations.
Thank you. Manny Lopes from East Boston Neighborhood Health Center, and I'm happy to be here today to talk to you a little bit about what we're doing in the community of East Boston as well as in the surrounding catchment area. East Boston Neighborhood Health Center is a large federally qualified health center. We treat over 80,000 patients. We're one of the only FQHCs with a 24/7 emergency department, which we could talk about how that helps in many different ways. We've also made a significant investment in behavioral health services, where we're working with our close partner, North Suffolk Mental Health Agency, and we signed a strategic affiliation last year, bringing our services closer together and hopefully providing better care to our community. I also want to mention that for over 30 years, we've accepted a global capitation payment in our PACE program of all-inclusive care for the elderly. When I looked at Lauren's presentation, it reminded me of a lot of what we're doing in PACE, where it is a hub and spoke model, and where we take full responsibility for the frail elderly population, including not only the medical care and the behavioral health care, but also transportation, meals, and housing. And then finally, I also like to mention, through the pilot program of the ACO, we are the founding member of a new corporation that you heard about yesterday, Christina Severin, our president, Community Care Cooperative, which now has 12 health centers coming together to be a community-based ACO. Thank you.
Good morning. I'm Spiros Atieres. I'm CEO of Holyoke Medical Center and Valley Health Systems. Thank you so much for inviting me to this panel today. I really appreciate the opportunity to address the issues at hand today. Just a little bit about Holyoke. I hope I represent fairly today the community hospitals, the smaller community hospitals, the western part of the state, the gateway city, and frankly, a population where, social needs and behavioral health needs are quite significant. There are many programs that Holyoke is involved in. I'm not going to list them all, but I'm going to point out that we're also part of a CHART grant to specifically address recidivism in the emergency room and trying to provide more linkages in the community and connectors for our patients to other services so that the emergency room doesn't become the first and sometimes only choice. Thank you again for having me here today.
Hello, I'm Elsie Taveras, and I am so pleased to be sitting in this panel with you all. I am a pediatrician and Division Chief of General Academic Pediatrics at Mass General Hospital for Children. I'm here representing Mass General, which in addition to our hospital in Boston, cares for families in some of the most economically deprived communities in Chelsea, Revere, and Boston and Charlestown. I'm especially pleased to be here talking about social determinants. As a pediatrician, those of us in the room know that social determinants might be a newer conversation that we are having, but we've been having this conversation in pediatrics for years. It was born in pediatrics because children are maximally dependent on their environments, on their parents, on the responsibility of adults who make decisions for them. And so we're thrilled that the conversation about social determinants has gotten out of pediatrics and is a much larger national conversation to be had about the health of our populations. And so I'm happy to be here to talk specifically about some of the programs that we are doing across partners, across Mass General Hospital. And for me, Lauren Taylor's presentation was music to my ears. I think we are all very thrilled that she is out there speaking about some of these important issues.
Great. Before I turn it over to my colleagues, I want to share a story. About 2 years ago, I had a conversation with a hospital CEO about dealing with the folks in the ER who came in with both mental health and substance abuse issues, and about engaging community partners in the effort to try to address their needs. His response to me was, there's no incentive for me to engage those community partners. And I said, well, under an ACO model, there's every incentive for you to engage them. And his comment was, there's not enough money in the ACO contract for what I need, let alone my community providers. I think I'm dealing with a more enlightened panel. I know I am. But I'm curious, particularly for those of you who are in the ACO business, sort of, is there enough in the contract to allow you to really engage community partners so as to deal with some of the social determinants of health?
I can start. I think the ACO pilot is going to offer a really fantastic opportunity. But still, there isn't sufficient funding for behavioral health integration. I think behavioral health integration is going to take quite a bit more of an investment, and it might be a partnership between our hospitals and Medicaid and frankly, the philanthropy, which unfortunately is what is funding a lot of our community partners. And to me, I think, as a clinician who knows that in Boston, there's an organization that can help my children and my patients by doing home visits, or who can provide social services support such as Room to Grow, or that there are services like community servings that can deliver foods to the homes of diabetic patients who can't make foods for themselves. It's, for me, an incentive to think about how do I get my institution, or how do I get Medicaid to together help us reimburse those services so that I can provide an electronic referral to that patient to be able to get those home delivered meals. And I think the ACO is going to actually lead us in the right direction to there, but I think we have to think about other creative partnerships and other ways to fund these really interesting natural experiments and partnerships.
Kate?
I'd argue there's two elements of a contract here. I think one, we are in the business of trying to get people healthy and keep them well. So I think we have a social contract, sort of setting the ACO aside. I think that at Boston Medical Center, we've addressed elements of that social contract in a number of different ways. So we have found largely, as Elsie said, through philanthropy, we have a therapeutic food pantry. Patients, you can get a prescription for food just like you can get a prescription for insulin. But I think it's actually more fundamental. I think the separation of behavioral health services, that people's bodies stop here, I think has really hurt our ability to care for patients. And as we look at every single health indicator we're trying to improve, we come back to some of the fundamental social determinants of health. We come back to behavioral health. And so I think it's actually in our self-interest to do this. ACO or aside, as we worked on readmissions, we found the biggest problem was behavioral health integration, and began to get to work on that before, when the ACO was kind of a gleam in our eye. So I think that as leaders in this business, we have to reorder our priorities a little bit more, even than we have been, because I think we'll be better partners. I think the trick for us is who and how to partner. And we're not great partners, we're big, there's lots of us. We have project managers, and you're talking to smaller organizations, and so I'd be interested in some of the panelists who have had more experience on the ground in the communities they serve, helping us all think about better ways to do this.
If I might, on the financing perspective, at Commonwealth Care Alliance's experience, we've been doing this for a long time, providing, we're fully capitated both from Medicare and from Mass Health to care for the totality of our population. That includes behavioral health, long-term service and supports, and a number of sort of additional services and benefits, including non-medical transportation, meals, et cetera. It is very apparent that the risk adjustment methodologies currently do not sufficiently address social determinants of health. And that is a problem for us, and it will become a significant problem as we start to expand alternative payment methodologies. And there's two components to that. One is we recognize, and there's significant literature that continuously reminds us of the impact of social determinants on health outcomes and health expenditure and utilization. But there is also the flip side, which we haven't figured out, is what does it actually cost to overcome those barriers? And we're hoping to contribute to the understanding about that through our experience with OneCare and with SCO, but I don't believe that this has been fully fleshed out. The other piece that I think is really important to bear in mind as well, however, is that setting capitation rates based on prior costs of care is dangerous because it runs the risk of codifying existing disparities in access and delivery. And so we have to be really careful about that. I think there's been lots of really great work to show that in Massachusetts that these disparities exist and that they're not predicated on health need. They're predicated on many, many other factors, many of which are socioeconomic, and we have to be really careful not to codify those in the future. And then on the delivery side, that's when it becomes very interesting, right? Now, when you have the resources, assuming you have the resources and the alignment and the incentives are in place to actually start to build those relationships with community-based organizations, how do you partner effectively with these small groups? How do you foster their ability to deliver the care that they need to do in the community? We've learned a lot, but I think as you start to scale this up, there is certainly much more to be done. And again, Lauren referenced the idea that there perhaps needs to be some sort of convener of these community-based resources, some setting of standards that is not too onerous for them, but that also enables them to interdigitate with the multiple players and payers in the system. I think that has merit, and would be really interested to hear others' views on that as we start to scale this.
And I would probably say a good example of what needs to be done is in the 1115 waiver, where there needs to be an investment before you could see the savings. And I think that this RIP dollars being allocated to CBOs and other community-based organizations is really a step forward in allowing us, because this is hard work. And we know there are opportunities for greater efficiencies. But before we get there, we have to make this investment. And then once we've made these investments and we've created these relationships, hopefully there will be savings in the system and enough money. Now, the trick to that is, to what my colleague said, is make sure that we don't have a race to the bottom here, and that capitated rate doesn't continue to come down, particularly as resources get restricted at the state level. If the state's our partner in this, we have to make sure that that amount is the right amount of money to sustain the system that hopefully will be in place after this is said and done.
Sure.
If I could just go back to your point about risk adjustment does not include social determinants of health. One can imagine ways to do that. Probably not scientifically validated, certainly from my perspective. Have you done this? Have you, and if so, what has been successful that you might want to share?
Absolutely. I mean, there's the first problem when you start to try to do this at scale is that we don't currently in the health system don't really ask the right questions and don't document it in a way that's really standardized and replicable. So, for example, ICD-10 for the first time has a code for homelessness, but we know that providers don't use it all the time. They don't ask the question, what about folks who are marginally housed but not homeless, who may become homeless? There are actually, I think, to Elsie's point earlier, the pediatric field, I think, has taught us a lot about how to quantify those risk factors. Our experience at CCA has been that our population, as you know, is all really challenged by social determinants, but folks who are homeless or marginally housed have significantly increased utilization and costs of care. And the systems that we need to deploy to care for them are more complex and more costly as a result. It's not a homelessness equals 2x or 2.2. I've not seen that anywhere. We were able, through our conversations with the state and with CMS, to really help to start to move that conversation as it pertains to our risk adjustment, our capitation for our population. But we're still looking historically and not necessarily prospectively. And I haven't seen yet a literature to support real prospective modeling. I don't know if others have, but it would be interesting to see how that then overlays and then to see how it's validated through our population.
Spiros, do you want to go?
Yeah, thank you. I wanted to address the issue of whether there's enough money, and I will say that, I'm not sure, but I will say that more work has been done, I think, this waiver around to really fundamentally address, how do we care best with the resources we have. I mean, we worked as a Disti hospital really closely with EOHHS, and I will say that the design of it in terms of the partnership with the CBOs and so on is certainly absolutely the right thing to do. But I do want to take a moment and say that too often I think we focus on how much, and certainly that's a question that's valid. But I think we often have to also introduce into our dialogue of when, we make this investment. Let me put it this way. If I decided 5 years before I'm going to retire that it's time to save up for retirement, it would be a big lift. But if I decided that at 18 and started saving little, by the time I retire, it wouldn't be a big lift. What I mean by that is I think we got to do a lot more to invest into families and children. I'm really glad that Elsie is here because let's remember the people that we see today as adults in our EDs, that started back, when they were children. And I have to say, and I apologize, I forget the author, but I recently read a book called The Boy That Was Raised as a Dog. And it's an interesting read. And if you read this book, you fully understand that the issues we're dealing with today in terms of behavioral health, substance abuse, are things that we could have prevented with more work and help when the individual was young. I will give you one statistic that I just pulled from our organization, and I'm not going to claim it's scientifically, statistically valid, but a lot of my folks told me about a wonderful program, they believe a wonderful program that was implemented here some years ago called CBHI, and they pulled some statistics for me. And so in 2008, from 2008 to 2016 in our emergency room, we have seen a 35.2% increase in behavioral health visits overall, 35.2% increase. But for under 18, we've seen a 36.3% decrease. So programs do work. I think it takes a while for them to mature. I think we need to invest for the next 20 years now, and I think that's the direction we need to have some dialogue.
Okay. Don, you had a question?
I'm having a thought that is new, and so I'm not going to be too articulate about it, but if I understand what you're talking about. So our charge as a commission is to control costs of healthcare, subject to constraints on quality and well-being. That you're making that sound wrong. Like, if, for example, if we capitate healthcare and regard that as the target, we're cutting off the best way we would have to control healthcare costs, which is to expand the pot by including the social determinants you're talking about. I guess where I'm navigating toward is the capitation might want to be capitating healthcare plus another cluster of determinants of health, like Lauren was talking about. That's what we're talking about? I warned you it was vague.
No, it's not vague at all. In fact, I think it's I think it's right to the point. And I think the point is that because we perhaps haven't invested as much as we should have, 20 years ago, we have to bifurcate. There has to be two strategies. We have the current situation we got to deal with, which is, we're dealing, I think, with some of those models and the capitation and other things. But at the same time, if we don't change the paradigm, if we don't at the same time invest so that 20 years from now, we have a better situation, a better outcome, we're not going to be successful. We're always going to be chasing that goal. So really, you're making a good point in that it is really a twofold argument. It's not one or the other.
And I would say, based on our experience in the PACE program, where the PACE program did not have a requirement for housing, but in order to, because we're fully at risk, and it's a global cap, in order to have an impact on the medical costs, on the total medical expenditures, we felt housing, of course, was an important component of that. Now, you could call us smart or lucky 30 years ago of understanding that there was a social determinants in terms of healthcare with housing. And we did the same thing with the Meals on Wheels program, and we opened up our own kitchen and provided nutritional meals to the elderly population, knowing that there will be an impact to the medical expenses.
Carol?
Thank you. This is such an exciting discussion, so I'll just make two comments and then maybe a question too. First of all, Manny, hearing from you, I worked at East Boston Health Center for 14 years, and two things struck me. One is that they were doing these kinds of interventions back in the 80s, and the other is that one thing we haven't really talked about is, as a way to integrate, perhaps connect better with this community, is hiring from the community. And I know that was the case when I worked there, that you use community people to work at the health center. And I think that's something we forget about, but if your workforce comes from the place where the services are being delivered, there's a much better opportunity for connections, and it's not going to cost you any more. In fact, it's going to improve the financial condition of the community. So that was one thing. And then I wanted to give a shout out to the American Academy of Pediatrics, has put out a policy statement on poverty and childhood health. And within it is the recommendation that pediatricians screen for social determinants, and a list sort of, we have access to various tools that can be used. Now, the problem is if you screen for something and you identify a problem, and Elsie will know this because she does a lot of work around obesity and nutrition, what do you do then when you've identified the issue? So again, we need to make those linkages. Okay, we'll have an answer to that. And the other question that I had has to do with behavioral health integration, because we have seen a lot of pilots where it's really shown a dramatic impact. But they're almost always funded, as you mentioned philanthropy, I think. So they're almost always funded through grants. And we have got to figure out the sustainability piece of that. So I'm curious what models you are seeing and able to use to sustain that kind of integration, or an integration of any sort of social benefit or action.
Both questions. I worry that when we talk about social determinants, which is absolutely critical to the work we all do and represent, and a big driver of healthcare costs, we get a little swept up in the enormities of the problems we're trying to solve. And I think that there are many, many patients who absolutely need a very different way of care, a very different model of care that CCA's developed, that East Boston's developed, that we're trying to develop. Everyone on this panel has figured that out. What we haven't figured out is how to take the existing healthcare resources and make sure that they get applied in a uniform and effective way. We were just talking about this. This isn't peanut butter. It doesn't go across the board. There are patients who really need it. And there are patients who would get stuck in it if we put peanut. There are many people who come to Boston Medical Center. Their families are relatively intact. They have jobs. They do their work. They get their care, the primary and specialty care they need, and they go home. Integrating behavioral health into our primary care practices is really important for many of our patients, but not all of our patients. And we, particularly as a hospital, have to be ready to take care of people in a very safe, standardized, and effective way. And if we go out and try to fix every social problem in the world, we risk the flip side of the social contract I was trying to inarticulately discuss earlier. So I'd argue that we need to figure out who needs these services, find a way to get those services to them, which is the work that CCA does so well, and let a good chunk of the healthcare business do what it is we do, because we have to be ready when somebody needs us. And I always use this example of, my team's sick of hearing it, but somebody falls and breaks their hip because they fell in a pothole on Dorchester Avenue, and they get taken to our emergency room, and they get put on an operating room table, and they're paralyzed, and they go back to the floor, and hopefully they go, there's a lot of things we have to do perfectly to get that person back to the healthiest life they can live. Am I responsible for the pothole? And what if I really thought about health, and where do our responsibilities begin and end? As a healthcare delivery system, we have to make sure that we apply the resources, and I think that does begin and end in many ways with behavioral health, largely I think due to the stigma around those illnesses. And if we could get ourselves more organized around it, if the case weight of severe and persistent mental illness was as high as the case weight for a bone marrow transplant, I think we would have a different healthcare delivery system. And so I was trying to knit both of those comments together. And one quick minute on childhood obesity. So at BMC, because we are, what we've done faced with kids who can't go out and play because of the neighborhoods they serve, they live in, is a jump rope clinic. So every kid leaves with a 79-cent jump rope, and before they leave, we test how many times they can jump rope, and then 3 days later, we test and say, hey, how are you doing with that jump rope? I mean, it's not perfect, it's not great, but it does, these are big, gnarly problems, but there can be very simple and straightforward solutions.
And I might just, if I could just sort of piggyback on, I think, both of these comments, which to me kind of come back to Dr. Berwick's question. What are we trying to solve for, and then what are the levers that we're using to actually solve those problems? And those are two different things. There's a pragmatic component to the first question, which is, well, we have to solve for rising costs and for the fact that we have a finite budget and that we have to be able to provide this and a whole host of other services to the population that we're accountable to. So yes, we should be solving for healthcare costs. Then what are the levers that we need to apply in order to achieve that? And that's different, to Kate's point, depending on what cohort of the population you're talking about. But you're battling with a handicap if you don't take account of and utilize all the levers available to you. And for a significant proportion of Medicaid patients, social determinants are a huge lever. And we have to both incorporate them in the delivery system, but also then in our thinking about the capitation structure to support that. And so, I think one of the areas that we really need to spend a lot of time thinking and talking about, with the limitations of the data that we have, which I sort of referenced a little bit earlier, is who needs what? It's not peanut butter, but we have a whole bunch of folks who are not getting what they need. And then maybe it's a jump rope. Maybe it is just that referral for a home-delivered meal. Maybe it's a ride safely to dialysis every 3 days. These are simple interventions, but we've got to be able to figure out who needs what off the menu and how we deploy that to them. And the other piece is that then we need to create sort of a policy structure and a framework that allows us to to break down the idea that healthcare is delivered in one place, which is a hospital or even a community health center, the place that is convenient to us as a system. That's what we do. Patients come to us, we do things to them, for 15 minutes, 3 hours, they go away, and their life is perfect. And we know that's not true. And we know that the 99.9% of the time when a patient is out in the world is actually the most important time to impact their health and their well-being. And for some people, they can get it together to ensure that that is optimized. But for many others, we're going to have to reach in. And that pothole suddenly does become a problem for me. You know, if I've got somebody who is mobility impaired, and they're risking falling all the time, then it matters that they live, you know, on Dodd Avenue and that there's horrible sidewalks. I may need to think differently about how I help them with their DME supplies and their assisted technologies to actually get around safely. So really understanding how we can segment our population and start to deliver care at a place that is responsive to and convenient to them, utilizing, I think, not just folks from the community, but actually folks in the community, using health and other professionals who are not necessarily in the medical model. So we've got a lot of benefit out of community health workers, health outreach workers, peer specialists, recovery trained coaches, folks who don't come in with the white coat and the stethoscope and all of the baggage that comes along with that, folks who really are able to walk alongside our patients in the community. We've gotten a lot of really excellent outcomes from our community paramedicine program, Mobile Integrated Health, sending paramedics to people's homes who are empowered to not transport if not necessary, who can treat patients in their homes. Our patients tell us that the stigma associated with coming to the emergency room when you have schizophrenia on your problem list, even if it's because you feel nauseous or you've had a GI bug, that impacts their health-seeking behavior and it impacts their outcomes. We know that. There's lots of data to support that. Providing care where people live in a context that is truly responsive to their needs is actually a really important component to that. But you know, not everybody needs home visits. So how do we deploy ourselves effectively and efficiently?
Great. Tim?
Go ahead. Okay. Great, thanks. Just digging a little bit deeper, I'm glad I got the question right after that answer. As a union of healthcare workers, clearly we care about and focus a lot about the impact of these changes and the role of healthcare workers, frontline caregivers, not just nurses and doctors, but also the whole healthcare team. I'm just wondering kind of how are you engaging, or have any of you engaging your workforce and how they can be a partner in helping to address these issues, understanding the problems and needs of patients, how they can play a key role in integrating behavioral and social determinants of health outcomes and control costs, and just wondering kind of what strategies are you using to engage the workforce in those conversations and questions, and are you seeing any changes in employment or new job titles that are being created, and working on incumbent worker training programs, jobs that were no longer going to be necessary in this new environment, training those workers to meet the jobs of the future. So just interested in that.
So first, I just want to give a shout out to the chairman in the back here, Chairman Sanchez, who mentioned yesterday that we have to stop talking about cultural competencies. And I think that addresses Carol's message around hiring folks from the community to care for the community. And with that, we at East Boston have opened up for the last 5 years now. We've had an education and training institution. And it's a program that goes unfunded, but it's really our responsibility, our way of preventing, to my colleague here to the left, preventing those issues that impact our community. So within the training institution, we are not only providing job readiness skills outside of healthcare, so things like ESOL, English as a Second Language training, HiSET, the new GED program trainings, but also providing community health worker type trainings, so folks are truly prepared to enter into the healthcare space. And then the second principle of the program is also for folks to get better at what they do, particularly your medical assistants, your registration, receptionists, and other extensions of the primary care team who really can have a great impact around case and care management for the populations that we're serving. Again, not only do they come from the community, they speak the language, but they also understand the culture. It's a significant investment, and it's something for maybe this commission to think about when we start talking about preventing some of these issues that truly have an impact in the cost of care.
If I can add to that, I completely agree. I think we obviously all have our offices of diversity and inclusion. We're obviously doing a lot to increase the diversity of our healthcare, workforce, and our medical residents. But I actually, this idea is one of what are the new job titles? And they are health coaches, they're patient navigators, they're case managers, they're community health workers. And those are new, and maybe new positions, but we have a whole cadre of professionals already in roles that are too narrow. For example, I love my dietitian colleagues, but in an age where chronic diseases are due not just to poor diet, but also to insufficient sleep and too little physical activity, to have a profession of just nutrition specialists and not expand that scope of that person who we already know how to reimburse, are already in the community health centers. I think it's worth us thinking not just about these new titles, but how do we retrain a workforce to be more cognizant of behavior change, more cognizant of social determinants, and how do we stretch the people that are already in these roles that can make a difference and can influence families and children to stretch them in ways that we really do need to go there if we are going to do anything about social determinants or behavior change. And it's not, in this example of nutrition, it's not just nutrition anymore. Yet we reimburse nutritionists, and we have a really great, fantastic model for doing that. So I would urge us to think not just about new positions, but thinking about the current scope of work of our current health professionals or paraprofessionals, and how we could think about broadening their expertise and help.
Kate, you wanted to?
I'd add two other points for this commission to consider, in that I think Toyin said the magic words, the medical model. So the work that the dietitian does to have to document so that we can bill is almost absurd. Certainly documentation for home visits, you might as well go to the hospital, it's quicker. And so I think that as leaders in advising our Commonwealth and even at the federal level around the regulatory framework around which care is delivered. And I think, Tim, you need to, as well, you need to keep challenging us because, we know the jobs we know how to do. It's harder to transition positions. How many people, think about how many people we have working in patient financial services, and how many of those would we need in an ACO world? And how many of those could become health coaches or work in the communities we serve? And I think that we need to work harder. And I think that if the transformation we're hoping occurs, there's going to be a lot of people looking for work if we don't do this right.
Stuart?
Yeah, first of all, I want to apologize to the panel because, and I want to blame this all on Don, because he asked a very important question, but which is much bigger than the discussion we're having. And I don't pretend to know but I'm glad Lauren's still here because she's going to answer this question over time. I don't think in my lifetime I'm going to figure it out. So the bigger question he raised, which is, if you look at the chart that Lauren pointed out and you combine social and physical health care, we're still above the OECD average, but we're significantly below a number of other countries. So in a very big sense, I hate to do this, where you say, is it A, B, C, or D, or all of the above? It is all of the above. I think we need to strategically add more money into social. And I just want to put a thing in, it is not just for poor people and mentally ill people. I think there's a lot of value even for the so-called well and the so-called high income that could also benefit for these interventions that reduce their need for health care. But I don't pretend to understand that, but I just have a feeling that it's not just at one level, it's across the board, but more so in the populations that you serve. So first of all, we do need to add more money. But we are never going to add enough money in social services that you and we need without reallocating it from the health care budget. It cannot happen unless we're prepared to substantially increase our tax structure, which I'm not against some of that, but it's just not in the cards. So we're going to have to reallocate the money somewhere along the line. And I think we are doing that, Don. I think we are slowly, as we move into paying for value and paying for quality, some of these quality measures, like in MACRA and others for physicians, are increasingly going to say, unless you participate and do these other things, you're not going to see any increases. As a matter of fact, if you're not careful as physicians, you're going to see significant decreases. And so we indirectly should be paying not only you, those of you who are providing disproportionately health care to our low-income population, but for the whole healthcare system, basically saying, you're not going to be not only you're not going to be getting any more money for just doing, you're going to actually get less, and we're going to the system is going to take that money and reallocate it so that we can get these bars, this ratio, better balanced. Is that, and how to deal with that, I think should be an area that we have a lot more discussion on. We obviously can't solve that problem, but as I'm listening, I just keep thinking about yesterday. We're already asking the private insurance to become the big ATM machine to fund our big healthcare system. That's a system that increasingly doesn't want to give the money. And they surely don't want to give the money for social benefits and take it away from them, even if what they're getting is not only useless, but harmful. But the battle that we're facing in our, I don't want to keep bringing up things, in our exchanges is in a very real sense there. So it's a very big issue. What you guys are doing is great, but I'm sorry to take it away from your time, but we need to be providing you, A, with more money, and how we do that is going to be difficult, and B, we're going to be asking you within yourself to be reallocating some of your healthcare dollars more for these social services. Does that make some sense?
It does, and I do think that the Mass Health Program is considering this and thinking about how to allocate those district funds, because I think that's a good way to kickstart some of these investments and to test some of these theories of change. By both supporting the delivery system, the big delivery system, in thinking about better how to interconnect with socially based organizations, but also providing some supports from the bottom up. And I think the bottom-up component is really, really important in increasing the capability of the folks who really are on the ground, on the front lines, addressing some of these social needs to actually do the work. And so I think it's a good first step, but I agree with you. And I think, Manny made the point earlier, and I believe it was you, that the lag time to benefit is long. And so we have a combination of significant investments required and a system that does not prize patience when looking at financial returns on investment. And this is not going to happen overnight. It will take years and years and years, and sometimes even decades and generations when we think about, the value of some of the work that we're doing, for example, with younger folks who are low income, disabled, 4 extra years of life for that person means that perhaps they can continue that part-time job and they can be a grandparent or a parent to a child, that they can provide a stable home environment for somebody who in the future may turn out to do okay as a result of that. How do you quantify that and that investment and the value of that investment? It's not going to show up tomorrow, because what it's going to look like is increased years with disability, and that's cost to the system. But what we don't see is the huge benefit of having healthier people, caregivers, providers, families, communities, and we don't have a system that understands how to prize that and how to value that. So it is there's patience here. We have to bake in some tolerance for that timeline into a political process that doesn't quite have that.
Spiros, you wanted to?
Yeah, I would say that Chairman Altman, you're correct in that, both have to be done. I think the providers have, responded to the need for reallocation for efficiency, sometimes voluntarily, sometimes, a little less. And so there has to be I feel there has to be a short term, and short term could mean 10 years, but pain where we make difficult decisions. I mean, we're working in the CHART program to reduce ED visits. At least in the current construct, every visit that stays out of the ED means revenue to the organization, but we know it's the right thing to do. However, we're always going to be chasing this if we don't figure out a way to, to invest up front. And frankly, I think when we look at the ratios, I know there was a lot of discussion about ratios, we can't assume that the amount of money we're spending in healthcare won't change either. If we invest up front, I think the amount we spend on the back end in terms of those high-cost interventions has to shrink, will shrink. And so the ratio will start balancing itself even from that. It'll take time, I agree with you. It won't happen overnight. It may take a half a generation or more, but we got to start thinking that way, I think.
David?
I was going to hesitate to bring up the economics, but then Commissioner Cohen and Commissioner Berwick brought it up, and Stuart, of course, opened the door fully, so I feel like I have license to do so. So it's clear that there are things outside of your institutions that you rely on to address the needs of your patients. And I'm trying to understand the economics of it for a second. So one issue is there enough of that supply? That is, are there the people in the community with whom you could reach arrangements and care for people? Or is it the case that that supply doesn't exist and the secretary should create said supply? She's running away, so she doesn't have to hear that. Alternatively, it may be, no, it exists, but the problem is there's upfront costs in working with these things. Like, we have to invent the process by which we're going to do this, and that requires people and institutions and so on. And so the real issue for us is not that it doesn't exist, it's just we have to find the upfront costs. Or is it really, no, it exists and we don't really need the upfront costs, it's just we're not used to working with it, and there's a sort of culture clash, and we have to figure out how to mesh our system with their system and so on. So I guess I'm sort of interested, how much and what is the money issue here relative to the other things that are going on, or the other things that could make it difficult?
I'll take a crack at this. I think to quote the chairman, it's a little bit of all of the above. I think it's there are places where we have inadequate supply. Behavioral health services has been targeted. There are places where we have supply, but the patients who need to access it can't, either because it's not organized in a way that makes sense for the patient or the patient's family. We're not open on nights and weekends, so it's hard for working poor folks to get to where they need to go. Well, we are, but in general, parts of the healthcare system aren't. And I think the third piece is that we do have some culture clash, and some of it goes back to the regulatory framework that we talked about as it relates to each of these roles. I do think what the ACO transformation and Mass Health will force all of us to do is to wrestle with this. And just like as a safety net hospital, we feel like, oh Lord, please don't move a penny, it's hard enough. That same agency that's, 3 blocks down the street that's dealing with autism spectrum disorders and it's a small shop is like, please don't bring BMC there, they're gonna take all our patients. So it's a very interesting walk we need to walk as an organization. We need to learn who's around us. We're actually mapping the community services that we would likely be working with, and it's embarrassing how little I know about them. I can rattle off for hours all the great community programs we do within our walls. I can't because they're in my notes, can't tell you much about what's going on, 3 blocks from our hospital. So that is the transition that the way this waiver funding is structured, to Mandy's point, we're going to walk that walk, and I think it's going to be a very interesting dialogue. We may know more even as early as next year. Some of you will have us back.
Kate, before we move on to someone else, if I could just add to David's question. You opened up with a compelling story about the pothole, and one of the things you said that was really important is how do you, as a health system, decide where your responsibilities begin and end? And David, I think that's a subset of the culture issue. So as we talk about kind of what force do the economics play versus what part does the culture play? Kind of how do you begin that process of really thinking about not just with whom do you partner, what do you make or buy, but how do you decide what it is you're going to do?
And I think the point I was trying to make, maybe inelegantly, is that what we do medically to people, we have to do perfectly, which speaks to a well-trained workforce, which speaks to a well-trained and empowered workforce. It speaks to cultural competence, even though we can't say that anymore. It speaks to understanding. Sorry, Mr. Chairman. It speaks to what our patients need from us. It speaks to much more respect for our patients than we typically offer, because I think if it was a lot of these things fall away if we hear more from our patients. And I think Toyin's point about the medical model really is the issue. If we try to address housing with a medical model, these are going to be the most expensive apartments on God's green earth. I mean, and so I want to be clear that you know, we live in a state that is, that, you know, we're privileged. We're working on the hard part of access now. You know, we've done a lot of the hard stuff. So let's figure out how, who the peanut butter, who gets everything, who gets much more, and then where do we go into real social service funding? Because in the countries in Lauren's study that do that, it's not run through academic medical centers. Housing isn't run through AMCs. Now, maybe we'll find that for a subset of our patients, we need to provide assisted housing because they have underlying medical conditions that makes it impossible for them to be successful in their home or to live healthily in their home. And that's the kind of thing we should be doing. But the fact that housing is unaffordable in the city of Boston should not be a healthcare cost issue, I don't believe.
Commissioner Lord?
Yeah, so I guess this is a question for anybody on the panel. You know, it sounds like workforce issues are a challenge for all of you, and you've all suggested that the needs in the future are not necessarily the skills that your current workforce may have, or that they need to be broader as you address these whole social determinants of health. And I'm wondering if any of you are in touch with our community colleges, our higher education system, our vocational schools, or our whole workforce development system to talk about what the skills you see in terms of your future workforce, so that we're beginning to address those needs now. So I guess anybody.
Yeah, absolutely. I think you're making an excellent point. And in fact, all of the above, we're, just an example in Western Mass, where, obviously workforce development and employment is an important issue for us, not just as a healthcare system, as the western part of the state. We participate in the Regional Employment Board. We are sitting on the Vocational School Advisory Committee. More importantly, I would say the biggest impact, I would say even before community college or any other higher education institution, is the work we do with high school students in Holyoke. There's a career point type program where we bring high school students in their last year of high school. They intern at the hospital. They're all local kids. And they discover careers they didn't know existed. The transformation in the kids is amazing. I mean, I bring them in, I meet with them at the beginning of their 6 weeks, I meet with them at the end. And to hear the stories is heartwarming, because they all almost inevitably find something they didn't know about, find something that inspires them. And a lot of times are those jobs that are the newer jobs. And so I think, really from a development of the workforce and what we need the future jobs to be, I think we need to engage in high school, and certainly with the other institutions, but early on.
So in our Education and Training Center, we've partnered with Bunker Hill Community College, UMass Boston, and now Becker College out in Worcester. Our partnership with Bunker Hill has given them the opportunity to learn from us as we learn from them. So they offer satellite classes in our conference rooms at the institute, as well as in conference rooms throughout the organization in the evening. They've taken, for example, our medical interpreter program and made it into a fully certified program within Bunker Hill that is now taught by our head of interpreting services department. So that's a great example of a community college understanding the needs of healthcare and developing programs to address those needs. And then at the same time, Becker College is has developed an accelerated master's nursing program, knowing that RNs not only need to eventually become BSN, but also potentially have to get their MSN. So we'll be offering those classes not only to our staff, but also within the community. And I think it's a good example. I also want to just switch and answer another question that Commissioner David, you mentioned around buy or make. And I know Lauren presented this. I'll give you another great example. Within the PACE program, we run our own transportation company. But the only reason why we run our own transportation company is because when we looked at wheelchair vans and systems out there, in East Boston, many 3-decker, 4-decker apartment buildings. And we could not find a transportation company that would truly carry, a 2-man carry, an individual from a 3rd-floor apartment into the van, as well as provide the insight of what's happening in the home. You have a valuable resource there that can truly understand if the person's not located in one of our housing units and they're living with a loved one. That's a valuable resource, and they couldn't provide that information back and become part of the care team. So we built, instead of buying, we built our own services. But today, there are organizations out there that are becoming more advanced in this area, and we are starting to buy those services in addition to having the insight. So I think it's just a matter of time, but there is that initial investment in some cases.
I could just chime in just briefly on the education and training component. I think the final piece of it is fostering interprofessional team-based education. And I think that is actually the most critical piece that we haven't really yet found a way to deliver consistently, with the idea that we've got all of these folks in the health system and touching the health system who have very, very unique areas of skill and expertise. How do they all fit together? Recognizing that, you know, as a physician myself, I think the primary care doctor, we're part of the problem, to be honest. You know, like the world revolves around me. I'm the PCP. It doesn't anymore. The community health worker has a role to play, and I've got to be able to interact with them appropriately. At CCA, our community-based organizations are part of the team. So our long-term service and support coordinator, which is part of a community-based organization. We contract with that agency, but we invite that individual who is coordinating home-based supports for our members to our team meetings. How do we talk to each other? Whose responsibility starts and ends where? These are all really, really important pieces of education and indoctrination and postgraduate training that are critical to ensuring that this works, because we no longer can function as professionals in silos, and we've got to be able to foster that type of training as well.
We actually use, it's some of these silos are so entrenched, we've taken to using our simulation center to practice, because it doesn't come naturally. It's been a very interesting journey for us.
Lauren, you had a question?
So there are already a lot of really great community programs that the state is currently funding, and so and as Kate pointed out, a lot of these programs have not been identified or you're not aware of. So what would be helpful for your organization to identify these programs out there, and is to leverage them where there's existing state resources going towards, and is there a role for the state to play in helping to coordinate and integrate, so that, you know, the programs out there are not only aware of the services that your organization is providing, but vice versa, that you are kind of aware of the smaller programs down the street that are providing these social benefits.
I mean, I can start with that since I raised it. I would say first of all, I'm probably the least aware, so, because I fly a desk, I think there are people on the ground at BMC who do know these programs and work with them every day. I think the intersection, though, between the work we do in our campus and what ABCD does, those kinds of connections need to be better fostered, particularly in the housing space. It's a little bit of the silos that Toyin referred to, that we need to think more broadly about health, think more broadly about services. That we do a lot of work in violence prevention, obviously, and through those programs we've met lots of people who are walking the same journeys and have different skills and programs to bring. I think it's less of a state issue and more of a care delivery issue. I really do think it's finding the people that our patients interact with when the 99% of the time we're not seeing them. and making sure that we understand that. So, and again, not every patient needs that, but there are patients for whom we might need maps of support systems because that's what their lives require. I think the structure of the waiver will also enable that because there will be people who will be both working with us and in some cases competing for dollars, so that will help clarify things. That tends to, when you follow the money, people tend to find their way to the right outcome. So I'm hopeful about it. I'm not sure that we need another state effort around this. I think we need, I need to get more informed, and it needs to inform sort of the strategic direction and investments of our organization in a much more community-based way.
Lise, you wanted to?
So if I can add, I completely agree. I think it's a care delivery issue. I'm not quite sure it's a state issue. So for example, the Prevention Wellness Trust Fund is creating this ability for me as a clinician, if I see a patient, let's say an elderly patient who's at risk for falls, they've created for me the ability to create an electronic referral from my office visit, my primary care visit, to a facility that can help me with that elderly patient. It's both universal screening, making sure that we are screening the elderly for risk for falls, making sure that we are screening for housing insecurity and food insecurity. But then my ability as a busy clinician to be able to, I'm not going to know all of those resources, but if we do the right geospatial mapping, if we do the right development of cross-sector partnerships and the development of those relationships, and I am able as a primary care clinician to do my job, which is to care for this patient and try to connect them as much as possible to those community resources. The best way to do that is to put it into my clinical workflow, right? And so I actually think the experiment happening with the electronic referrals and the assistance with building that capacity, let's get away from this issue of firewalls. I'd like to place a referral to the YMCA for my child with obesity who needs those services, and I'd like to know how my patient is doing if I send them there. So I do think it is actually a clinical workflow issue. If I could go back, Commissioner Cutler, you had asked a question about, do the services exist? And I'm struck by that because, again, maybe because I'm a pediatrician, I'm always used to fewer resources and making do with what we have. I think, there's a really great example happening right now in our state with the investment in substance use and investment in recovery coaches. And I, as a pediatrician, see that tremendous investment and think there's so much, and there's a lot. All of our institutions are really thinking carefully about how do we put those resources into best use. But if you look at the statistics about when substance use experimentation happens, it's at 12 and 13 years of age. And so when I look at that investment, what I'd like to see is some, and not so much equitable, because it's not an issue of equity, it's for us to be forward-thinking in putting some of that investment in prevention of children from even beginning that substance use experimentation. And so I think a lot of services already exist. I think there are ways to make us aware of others in the community. But I would also argue that even when they do exist, there are ways to expand their effectiveness, and prevention tends to usually be slighted in some of those efforts. So.
No, Ron, you had a question?
Thank you, great discussion. I've been here listening and trying to absorb all of this. And here's my takeaway. I'd like you to give me some direction. For example, prior to you coming, addressing the commission, Lauren mentioned that housing is a key issue. And Kate, you said, you don't want us being involved on the housing, and I can understand that. And at the same time, so you don't want to be that hub. You'd rather be a spoke. Manny, on the other hand, he actually has become the hub. I'm not sure how effective, necessarily from your own perspective, you've been to date, becoming the hub. But when I look at, as the business guy, right, I look at this and say, okay, there's some conflict in terms of, even if you do want to be a hub, what those spokes should be, right? In your case, it shouldn't be housing. Where will your business be, if I can use that term? What will it look like? What will the model look like 5 years from now, 10 years from now? How do you folks see it evolving?
What I tried to say, and probably said it inarticulately, is there, the affordable housing crisis in the city of Boston can't be solved through a medical model. There are patients for whom housing will be one of the better things we can do to get them on the right track for health. And I was trying to draw a distinction between that. I did it inelegantly, and Manny's always right and I'm always wrong.
How did this become Manny Kate? I'm gonna save my colleague here by saying what she is right about is the fact that we cannot give all the resources to individuals who don't necessarily need them. So we, again, invested in housing for those that needed housing. And we did not build it. We actually partnered. So we partnered with the East Boston Community Development Corporation and went after HUD 202 grants and built these housing facilities that are now managed by the CDC. So it's a great way where, again, you're looking at partnerships within the community to help deliver a service that you know will impact the overall cost of care for those individuals that need it. Going back to Kate's analogy that I think we all love now, the peanut butter. And it is the right services, right time, right place. And I think that is one of the challenges in trying to not only have a full scope of services that are available, but then trying to make sure you identify the right time to provide those services to the individuals that truly need it.
What will be the key spokes in the future?
I think what Lauren showed earlier, I think she really addressed a lot of those key spokes. Again, when I go back, I sound like a broken record when I look at the program of all-inclusive care, the PACE program. That it looks just like that, and we are the hub within that spoke, and we feel comfortable in that position because, again, we are incentivized in a global cap to try to do whatever is necessary to bring down the cost of care or try to control the rising cost of that care. So one could say, again, a global capitation program where someone truly, the incentives are aligned, will force organizations like us and others to hopefully spread that dollar in the right area.
We probably have time for just one more question, Don.
You have 6 minutes left and I have a 10-minute question, so.
You're out of luck.
I had a dinner a number of years ago with the Director General of Health for New Zealand, and I asked him, what are you proudest of? And he said, oh, just last week or something like that, I went back to the legislature. We'd just gotten our budget. I went back to our legislature, our parliament, and we returned X million dollars on the condition that that money would be spent on housing. The guy was very concerned about asthma in the community, and he had figured out epidemiologically the way to tackle it was housing. There was a reallocation process. Trying to bring this home to policy, some stuff we might comment on, it's the wrong pocket problem that Lauren gave vocabulary to. So here's the deal. If, let's assume, just simplification, that it were housing. I know it isn't, but let's just say we really could control healthcare costs. We really could knock the socks off well-being in the community if we just had better housing. Make that up as a hypothetical. We can't do that unless there's an ability to reallocate, because there's no more money, like Stuart said. So there are two. I can think of two possibilities. One possibility is that you reallocate. You save money somehow under cost constraint, but can use that money to build housing. So question one is, do you try to do that? Manny, you do. Is there something statutory or regulatory in this state that makes it harder for you to do that? That is, can you reallocate if you're willing to be the hub that Ron was asking about? I guess the second question is a budget question, which is the way you'd have to think about that, since we're not New Zealand, is to have somebody thinking about the combination of the healthcare budget and the housing budget, which could be done, I suppose, as a matter of public policy. I don't know how to solve that one, but you just would make a larger pot and then save money in that larger pot by reallocation. I'm asking a question about whether you can move the resources when you really know that they should be moved.
So far, we're partnering with REITs to do we're partnering with the Real Estate Investment Trust to see if there's a way for us to build immediately or nearby housing for patients that we know will benefit from that. We have a program out of our emergency room it's called Use to Home, High Users of Emergency Services, where these were 35 gentlemen, I think, well, there was one woman in the pilot who racked up $8 million of Medicaid charges in a year, and with assisted housing, which I think cost $189,000. I might have the numbers not exactly right, dropped their ED utilization to almost nothing. So there are definitely ways that we can and should be involved. I think for us to reallocate money to housing, we have to have a surplus, because presumably we're doing really well in terms of taking care of the patients we serve, and those resources are spoken for. So for us, it's often experimentation, to Elsie's point earlier, it's philanthropy, it's partnership, to Manny's point, it's, and the question, I guess the open question is whether there's enough incentive in the waiver that we're hopefully signing shortly for us to do this ourselves, or whether it needs an additional policy push. I would argue that give us a year or two. We're in a pilot phase now. We'll have a couple of years of opportunity to see what investments we need to make for our patients, because they need to help guide us through this process. This is not. I'm not sure this is stroke of the pen stuff. I think it's very much. It's very grassroots, and the waiver has enabled and actually required us to work with community-based organizations. So I'd give it a little more time personally, but maybe I'm just a chicken. You try it.
No, I mean, I agree with you. I think again, this speaks to this is the peanut butter. I'm really going to use this peanut butter analogy after this. But the idea, this is not a homogenous population. This is incredibly heterogeneous set of folks, and we need to have much more sensitive tools, to Elsie's point, for screening, to identify people who are amenable to these very, very high-cost interventions, very intensive interventions. Because if within your cohort, for example, Kate, you were able to identify the 300 people for whom an investment in housing, actually building, procuring, whatever it is, will yield 800x returns. You're going to do that because it makes sense, and you don't need to wait for a surplus. You could do that today, and you'll see the savings on your next year's acute ED visits. For the next cohort down, perhaps it's just the math doesn't quite add up, but by facilitating better communication with folks in the community who are already empowered to do this work, folks who are doing advocacy and outreach and engagement with housing, getting them a caseworker, getting them a little higher up on the list. That might be all you need to do as a health system to start to realize those returns over time. And the same goes for, pick any other social determinant. For some folks, we want to provide them with meals. For others, perhaps we want to support their daughter to get a few hours as a PCA a week so that she can make the meals. For others, maybe we want to get them a nutritionist so they learn how to cook slightly better. It's not ever going to be a one-size-fits-all. And what we have to be doing, though, is creating alignment and of incentives such that should Kate feel that she needs to make that investment, she can actually do that and reap the benefits from it, and that she has the tools to do that.
And I would add one last point, which is from a policy standpoint, being kind of liberated from the medical model, in a safe way and in an effective way, but the dietitian billing question, is really sort of.
Just last word.
Yeah, I just want to, last word, okay, so here's my last word. Some reallocation is happening, I think, under an ACO model, that's certainly going to be encouraged, but I would challenge everyone in this room, including ourselves, that at the end of the day, if you're given a half a teaspoon of peanut butter, you can't make a peanut butter sandwich, no matter how much you spread it, I don't think.
That's the analogy we are going. Again, you're wonderful, all of you. You took the task and you hit it really out of the park. So I want to thank the panel. It was a great job. Thank you, and we will be working with you as we move forward. Thank you so much. As I said yesterday, we are trying something new this year, and that have 2 reactor panels. One dealing with the employers, which we talked about yesterday, and now we're going to focus on our consumer reactor panel. So I'll ask the panelists to come up, and I'm going to turn the microphone over to Dr. Allen.
Said he's quiet.
Good job. Good
It's good to be exact.
Right, exactly.
All right, can I get this crowd back together again here? Carol?
Yes, thank you. Thank you, Mr. Chairman. So our reaction panel now is giving us a different perspective, that of the consumer. I have to say, as a physician, I actually don't like that term consumer, and I hope we sometimes I call them patients, but they're not all patients, they're people. And so if you guys can come up with a better term, I'll be really receptive to that. But I guess one question is, well, let me frame it as, we've talked a lot about some of the needs of the community, using community resources, community workers, partnering with community. I think it's important to understand what is the perspective coming from the community and also from the patient. I've been a patient, and I know that you have a totally different view of the healthcare system when you're on the inside than you do when you're in just, trying to design it. And I think that unless we do partner with the people who use the system, we won't design it correctly. So we're looking forward to hearing your reactions to the panel that we just had, because I think it really did address a lot of the issues that confront people in communities. And how do social determinants play in? How should they be addressed within our systems? And how can, quote, consumers be meaningfully engaged in this whole dialogue? So please introduce yourselves, and then with a brief introduction of what you're doing, and then we can ask you questions. Thanks.
So thank you very much. This is a pleasure to be here with you. My name is Alice Demner, and I work with Community Catalyst. And for those of us who may not know us, we're a national group. We are homegrown here in Boston, but we now work across the country in 43 states with consumer and provider groups to improve the healthcare system so it better serves everyone. Our focus is raising the consumer voice, consumer participation in health decisions, whether that's in their individual health decisions, it's a system level in terms of the providers and the managed care companies, or whether it's at the policy level at the state or federal level. My specific role at Community Catalyst is as a program director for our work on substance use issues and also with justice-involved populations. And I will want to raise that issue because I think we have not talked at all about another whole big stream of money we have in this country that I think is inappropriate to think about reallocation, and that's the criminal justice stream and the overlap that plays with the health system. I also am a senior policy analyst for long-term services and supports, working with our Center for Consumer Engagement in Health Innovation. And a part of that center's goals is to address social determinants and to revamp our health system to address all of consumer needs, not just their health needs.
Hi, I'm Brian Rossman. I'm the Policy and Government Relations Director at Healthcare for All. So Healthcare for All, we see ourselves as the voice of patients and consumers, and I think you're right, Carol, of all people, all residents of the state of Massachusetts, on healthcare issues. And we were very involved, of course, in the passage of the 2006 health reform law, and then with Chapter 224, the law that led to the creation of the HPC. And we continue to be involved, particularly in cost and quality issues and making the healthcare system work better for patients, for consumers, for everyone in Massachusetts. I do want to talk a lot when we get to the questions about social determinants of health and what the state can be doing, but I don't want to lose the thread of earlier this morning and of yesterday on prescription drug prices, and we want to lay out today a comprehensive plan for Massachusetts to do something at the state level about the high price of prescription drugs.
Hi, I'm Alexis Snyder. I'm a patient family advisor in the Boston area. I have served as a PFAC co-chair in a local children's hospital, and I've sat on other healthcare quality commission committees as on the not only on the patient side, but from the healthcare perspective, having worked in the healthcare system as well. So I am kind of intertwined in both perspectives, but certainly more as a patient and more so as a caregiver these days. I also sit on the Improving Healthcare Systems panel, advisory panel for PCORI. And I bring my perspectives of patients and families to the planning and the development and implementation of evaluation and policies and research that of course affect that care of the patient and the patient's outcomes and what's important to the patients. But more importantly than the roles that I serve, and I should also mention my involvement in Healthcare for All as well, where I sit on the PFAC Leadership Network Committee for Healthcare for All. But more importantly, I'm a mom of an almost 14-year-old teenage girl who was born with complex medical issues. And so me and my family know very firsthand what it's like to deal with the costs of the system and how those costs affect our family directly and other families in our communities. And we have direct connections with having worked with the Health Connector and having been and receivers of secondary insurance through Mass Health and the coordination of those benefits. And not only the coordination and the frustrations of those benefits, but the coordination and frustrations of dealing with multiple hospital systems where one system can't service all of our complex needs. And how do we access and coordinate the benefits between multiple systems and multiple providers, where definitely I would respond to the silo portion of the panel before us, where not only does the system tend to work in silos, which we see as a family with my daughter and as other people in our community see between the hospital systems, it happens within the hospital systems as well. And so if we can do something to improve the communication between systems, but also start with the communication in one system and get everybody working together, to use an old tagline, it really does take a community. And to really borrow that peanut butter line, once you spread that peanut butter, we kind of also need the jelly or it's kind of too sticky. So you need to involve other people into the pot, so to speak. And I'm looking forward to addressing the panel questions today, and specifically to what Carol had just brought up about why it's so important to involve patients and caregivers in the healthcare system.
Do any panelists want to, any commissioners have questions for the panel? So maybe I'll just start out. So things that you heard, of the things that you heard in the last panel and all morning, I guess, and even yesterday, which do you think are the biggest barriers to really making the system more conducive to taking care of consumers or patients, or meeting the needs, I guess, of consumers? And with those barriers, how can we address them? What are we not doing that we should be doing? Or what are we doing that we should do more of just in our systems?
Sure. So I'm sure we're going to have some different priorities here, but then I think that speaks to the diversity of consumer voices and thinking that one thing suits all. We've been a lot of discussion about consumer assessment and really reading the community, and I would say that that's the first major failing of our health system, and that needs to be addressed if we're going to address anything, is that for the institutions that are trying to serve the community to go out in the community and do in-depth community needs analysis to find out not just what the health needs are, but what all those other social service needs are, what the behavioral health needs are. And so to get that from the community, consumer voices across the community, different communities are going to have different answers to that question. And so I don't want to stand up here and say that I can tell you what are the biggest barriers to consumers, because I will speak to some, but I think it's important for each institution that's trying to serve the community to go out and really find that. And while I respect very much the providers who are here at the table and are some of the most progressive in the Commonwealth, I would say if you don't know where to look in your community to find the community providers who are doing this work already, you're not doing your job. That part of your job is find those out. You shouldn't have to have somebody give you a list of those. If you don't know, you need to get out there. And that's really is part of what your job is. So I wanted to start with that. I think in terms of some of the specific things, I think the siloing that was talked about and the division between the head and the body and between the body and your surroundings, and we all know we are part of our environment, so that all of those disconnects are really, I think, the crucial barrier to having a healthier community, healthier individuals, a healthier society. And I think that we really need to develop those new models that we're working towards, but I think sometimes we're not even thinking big enough. In terms of, as I said, thinking of some of the broader streams that we have of financing and of intersecting problems across our society. And I'm not saying the health system has to serve all, but the health system and the focus right now on the health system could be the catalyst that is going to turn things around and bring things together. So I would say that those are a couple of things, I think, that lack of knowledge of the consumers and going out into the community, and that issue of really needing new models and thinking much broader than just health, or how do we braid health and social services money together. Yes, we need to do that, but I think we need to look much broader. And there's work already being done, a lot of work being done already across the country, and we can speak about that if the panel's interested, in terms of looking at how do you braid, criminal justice resources and health resources and social services together to address some of the most needy in our communities.
So I would start by saying that certainly we agree with everything Alice said, and looking at these criminal justice issues and looking at the behavioral health system and finding ways of integration is really important. I want to bring up three things that haven't been mentioned today because I want to just put more stuff on the table, I guess. One is, actually, we did mention the Prevention and Wellness Trust Fund a little bit, but I want to remind policymakers that that is up for reauthorization in the coming session, and if we want to continue the good work that that's doing, reauthorization is a time to look at it and how to strengthen that fund and the work that it's doing, and broadening its scope and making it more inclusive, I think, is something that we need to be looking at. So that's number one. Number two, an issue that has not been raised is oral health and the importance that that plays in overall health. And we think there's some savings to be found, definitely, and there's some health improvements that need to be found by integrating oral health as part of the overall health system and making dental care and primary care work together, and bringing oral health issues into the healthcare system. And certainly that Mass Health waiver is an opportunity to do more on that side. And we're hoping that the Mass Health waiver is an opportunity to look at bringing back some of the dental benefits for adults that have been cut in Mass Health and figuring out how to integrate that. And then the third thing, and the big nut that I want to mention is, we believe in payment reform, we've used payment reform, but can we use the payment system to incentivize some of these other things that we know is important? And I want to particularly mention what's called patient activation or patient confidence, ways of measuring how well the patient is part of the system of care, how well we're using things like shared decision-making, and techniques that we know bring lower costs and improved outcomes. Can we reward providers? Can we first incent providers to measure this, and then reward providers for doing better on some of these measures of patient activation, patient confidence? And that's something I'd be happy to explore with the panel if there are more questions about that.
See Karen?
Okay,
Yes,
go ahead.
Karen, and then Dawn.
Would love to hear from the panelists how you would answer Lauren's question about who should sit in that hub. We've heard a lot of testimony and discussion today about better coordination, not just within the medical system, but clearly as broadly as between healthcare dollars and criminal justice dollars. So who sits there?
Well, I think everybody needs to be at the table, and who's at the center is a real tough issue, and I don't think there's an easy single answer. But it needs to be decided at the community level, I guess is where I would come down, is that the community needs to be involved, not just the players, the institutional players. There needs to be a way to involve, and so, for example, if you want to talk about PFACs and the role that PFACs play in hospitals, patient family advisory councils play a critical role in helping hospital administration figure out what the community needs are and what the demands are.
That's absolutely true. So I'd be happy to talk about PFAC effectiveness and how that helps bring that community piece in and only helps drive down the cost when we really involve patients in the care. We can't really do anything for patients without patients. And I think there was a doctor on the panel before us who spoke about how the term used to be that everything was about the physician. Everything started and ended with the physician. And certainly in our patient-centered world today, things have taken a big turn for the better, especially on the patient and caregiver side. And you really can't be patient-centered these days without involving patients. And so fortunately, we live in the state of, or I live in the state of Massachusetts as a patient and caregiver. And in 2008, Massachusetts enacted the law requiring patient and family advisory councils. And what a terrific thing that's been. And in that short period of time, once the councils got started in 2010, in less than 6 years, 90 hospitals to date have active PFACs in their institutions. And why is it so important that we involve patients? Patients and families are the core of our healthcare system, and they should be valued as members and be participating in affordable care design and government's teams. To be truly patient-centered, as I said before, nothing can happen for patients without patients. It's very hard to have the perspective of what can be good for a patient or what you think might work best for a patient until you've walked in that person's shoes. I can't tell you how many meetings and how many places I've sat in on both ends of the tables, but more so as a patient and a caregiver, where I've brought up a topic for advisement and brought up how it affected not only our own family as patients and caregivers, but the others in our communities and beyond. And I can't tell you how many people have stopped and said to me, wow, I never would have thought about it that way. And that's what really makes the difference in involving patients and families. If you don't understand what's happening, and you can't possibly begin to understand with some of the complex cases in our state and beyond, until you've experienced that and hear it from the perspective of the patient and caregiver, you really can't begin to make good change. And again, like I said before, once you involve patients, it can only help increase satisfaction for everybody involved, for the patients, for the providers, for the payers, for the ACOs. And everybody wins, and hopefully patient outcomes, the satisfaction of outcomes increases, and those costs go down. So it's very important that we keep patients involved.
Alexis, as a commission, we couldn't agree more. We, in our ACO certification program, have made a requirement that ACOs have a PFAC and that have a patient representative as part of the requirements of that program. I'm wondering if you can share with us a real tactical, specific example of a moment when you brought something up, either through a PFAC or in your role as a caregiver, that challenged the way that the care was being delivered, or challenged an assumption that someone had made and resulted in kind of a better care situation, just to give us something tactical to think about here.
Sure, I can give you, some larger PFAC examples as well, but the one that more recently is a personal one that jumps into my mind when you ask about accountability and how does that affect the thought process. There's actually something that I've been working on in our own primary care office from where my daughter receives care. And it's not something that's been completely worked out yet, but the perspective is on the table, and we're beginning to look at ways to change that. And this recently happened. My daughter and I went to an appointment, and this actually happened 2 or 3 appointments in a row now before it really hit me to speak up about it and say, hey, you know what, this isn't really working right. And my daughter and I went home and spoke about it, and she also had perspectives that I hadn't thought about that I was able to bring back to the table. And that was around, again, going back to the efficiency in the office and looking at value versus volume. And so this particular office was getting incentives to get patient notes out quickly, which happens through all of our hospital systems, which in the end seems like a great patient-centered outcome and should be something we look at. Are we paying for physicians to get notes out quickly? However, we've had issues not only in this office but in the hospital systems where things like that happen. The patient really isn't at the center of that, because what happens is the physicians and the other providers are so quick and worried about getting out accurate, quick notes that you get them back incorrectly. Or sometimes they pass it off to a fellow or a resident who doesn't know anything about that patient, and I have literally seen it happen. They go back to records from 5, 6, 7 years ago that aren't pertinent anymore and cut and paste things because they're so worried about how they efficiently and effectively can get their job done. So that's one piece of it. But what happened more specifically recently in the primary care office was that to try to combat this problem and to make things patient-centered in the end for the patient, which started with making it more effective and more efficient for the provider, was to bring in a medical scribe during an appointment. For us, we're not the average patient. We don't go to the doctor once or twice a year or for a cold in between for an annual physical. When we see our provider, we probably sit down for at least 45 minutes to an hour and review the multiple specialists we've seen over that quarter period of time that we haven't had with this primary care physician. So when we sit there, we start to divulge a lot of information about a lot of other specialists and everything about our care. And as I sat there for the first time, not knowing ahead of the appointment that this medical scribe would be in the room, I became candid about what I spoke about. I've always been very open with this physician. She's almost a part of our family at this point. And I kept pausing and stopping and thinking, what can I say, or what should I stop myself from saying that might be construed in a different fashion? That this medical transcriber might be writing down something that my primary care physician wouldn't have written down, that she knows it's a topic of conversation between us. So I really went home and I thought about that. And then when we went back a second time, this time actually for an annual physical, it really affected my daughter. So this time there was a young male in the room. My daughter's almost 14, and he was in the room for the entire appointment. He was in the room when my daughter's back of her shirt was raised for the physician to take a quick listen. Nothing was exposed. I didn't really think too much of it until we left, and my daughter brought it up. She was very uncomfortable, of course, being in that awkward teenage period, being a girl and having a strange male in the room while she was getting an exam, and somebody also there typing in her answers to the questions that were important about behavioral health issues and social issues and things that the primary care doctor normally is very easily able to speak with her about. So she too was candid at that appointment. So even without the facilitating of a PFAC in this environment, because this is the primary care office, and that's actually something on my agenda that probably should be mandated eventually into primary care for PFACs and into specialty offices as well, would make a large difference. But this is just one small example of how we were able to bring that back to the office. And again, the physician and other providers in that office actually said, like I said before, wow, we didn't think about that. Oh yeah, we didn't think the implications that that might have with a third person sitting in the room typing the information. We talked to them about confidentiality and non-disclosure, but we never thought about how the patient would view it. And so that's a real prime, fresh example in my mind of how listening and hearing back from the patient can make a big difference. I don't want to take up too much time, but I want to give you one larger example from one of the PFACs in Massachusetts. This hospital had gotten back low HCAP scores, and they actually sought out the PFAC to help them counsel on that and analyze the results and try to figure out why and what they could do better. They went to the PFAC, they consulted with them and trained them on how to look at the data and analyze the data. And then they met with the nurse manager, the PFAC met with the nurse manager, and they were able to provide additional interpretation of those results, again, from the patient perspective, that nobody had looked at. And now they meet monthly, and they meet with the nurse manager, and they write up summary reports based on what their analyzation was of those HCAP scores and where the real problems are. And that's making a big difference for that hospital.
Thanks a lot for that, Ms. Snyder. Alice, in your opening comment, you opened the door to discussion of criminal justice, and I think Brian also had something. Can you expand on that? What are your recommendations about frontiers there?
Absolutely, and I will ground this by saying that this is a new area for Community Catalyst. We're a health advocacy organization, but we are involved in the same learning and growing that you are, I think, in terms of expanding to social determinants. One of our new projects that we've been working on now for a little over a year involves working to support pre-arrest diversion programs across the country. Many of us are familiar with drug courts and things that happen later in the criminal justice system. This is trying to identify people who are at risk of arrest because of behavior, particularly because of behavioral health, substance use issues, and to create by bringing health resources together, exactly what you're talking about, hubs of care and services that can support folks and give them what they need, which is usually maybe treatment, sometimes not even treatment, but often is more likely the first needs are housing, food, and other social determinants. So these systems are being created, mostly at the municipal level across the country, and we're supporting them and particularly looking at supporting the engagement of actual people who would be participants in the program in designing them. And these are combining streams from Medicaid, from the criminal justice system, because in many cases, law enforcement has to have buy-in because these are folks that they would otherwise be arresting. That's the main model that's being developed, though we think there are lots of alternatives to work with social service providers, homeless providers who are not criminal justice officials. But so it's already pooling those streams as well as the housing streams in terms of supportive housing, recovery housing, if that's appropriate, housing first money. So it's already happening in these small models, and I think we can look at that and look at how those are beginning to evolve and think, how do we adopt them and adapt them, I think, for other populations as well. But if you're talking about a high-cost, high-need population and looking at the cost sensors and how do you bring down the costs, that's a big place, I think, to start, and there are those good examples out there.
First, I'm going to apologize to myself and to the panel. To myself, because we left out somebody else sitting at that table, which I'll take responsibility for. And this goes back to your comment originally, Carol, about why the term consumer should be there and not patient. And let me go back to the past discussion. If I look around our healthcare system, and I keep thinking about this, who's going to pay for social determinants? How do we expand? What's not at the table, and I'm going to ask Brian because I have such respect for Brian and Healthcare for All, he can do anything. And we need to think about the family that is making, I don't know, $40,000, $50,000, $60,000 that's not being subsidized, that may not even be subsidized by their employer. And we're asking them to pay $24,000, $25,000. And if I'm a big fan of the Affordable Care Act. I love it. But if the Affordable Care Act blows up, it's going to be over one issue. It's going to be over that issue of the exchanges blowing up, not because they're not working, but because we're asking a subset of the population that's not being subsidized and to pay a huge amount of money, and built into their services is a whole bunch of services that they don't feel they want to spend money on. And yet we need them to spend money on. So consumers are more than patients in our healthcare system. And when we talked about yesterday, we are asking the private insurance system to heavily subsidize our whole system. Now, I say that not negatively about the government. I think the government is doing everything it can, and maybe it could do a little more, but to ask it to do a lot more in that is very hard. So my question to the group is going back to the question I asked the last time, but really focused to the extent that you want to, and you don't have to because it's not necessarily your roles, is that if we're going to move forward in expanding the social services and social determinants, can we reasonably expect the healthcare system, and particularly those individuals that are being asked to pick up a large chunk of this $24,000? And I don't want to say anything negative about the employer community, but they are protecting themselves increasingly. They are not raising their proportion nearly as fast as premium. The biggest growth in this country for healthcare is being picked up by the worker. The worker, not the employer, is bearing disproportionately the brunt of the last 10 years, and yet we need them to do this. So if you could expand, and particularly, Brian, because of your role in Healthcare for All and thinking about us all, is this an unfair thing for you to take on? And I wish you would.
So the philosophical stuff is very hard to get into, I must admit. And I think we're lucky in Massachusetts that our connector provides deeper subsidies than the ACA provides. So we're doing our part a little bit to help people at that middle income level. But there's one thing I do want to put on the table as a specific policy response. And that's this broad concept that people call value-based insurance design. So to use the cost sharing, which is the highest part that people have been paying, that's the part that's been going up the most, is deductibles and co-insurance even now for a lot of people, and certainly co-pays have been going up. To use the insurance design to send signals that we want people to invest in preventive care and to do the things that prevent costs down the road. So for example, I just got yesterday a refill of my asthma inhaler, which I use very rarely, but it actually expired with a lot of dosages left. I need to get a refill. And the copay for my very good employer plan was $50. And is that fair to expect a middle-income person to be investing that type of a copay for a preventive care thing that's really cost-effective? And so one proposal that we've put on the table at Healthcare for All is, we call it the no copay bill, to not charge copays for some very cost-effective preventive care treatments. The ACA eliminated copays for a bunch of preventive screenings, but for preventive treatments, there's still a very high copay. And that's something I think we could discuss and talk about, is things like asthma inhalers or insulin for diabetics is another thing that's gone up and up and up. And the copay on that is astronomical for a lot of patients. And maybe we should think about not charging copays for things where, the copay sends a message, we want you to think twice about using this drug. But we don't want you to think twice because these save so much more down the line. So that's a practical answer to a very philosophical question.
Well, I wish it was philosophical. It's not philosophical anymore. It's very practical. And I would just say this, Brian, putting the copay and putting it on the insurance company means they're going to put it into the premium. They put it into the premium, that $24,000 will be $26,000.
Well, here's the thing. If adherence is low because of copay, and if we think these things save money down the road, and for a lot of these, the evidence is pretty good, then it doesn't have to go into the premium.
But how do we measure adherence?
Yeah.
But how do we measure adherence? I mean, I
Well-
don't disagree with the logic, but if they're going to Stuart's point is, and I want people to be screened, but it's not free. I mean, there is a cost. It's not the patient, the consumer's not paying for it, but it is being born somewhere and then coming back out someplace else. And I think it's just something we have to grapple with in terms of what is the right, where is the balance? I mean, it's not balanced currently, but it is, when I was teaching, and my students would say, there shouldn't be copays anywhere, and I'd say, well, it's not free. Where do you think the cost is going to pop out in the healthcare system? And inhalers are a good example. We'd want everyone, right, because it's very effective. But then how do you know whether it's being utilized and therefore should be free? It's just, I mean, I think we're in one of those conundrums, Brian, at this point.
Yeah.
I
guess.
want to
Go
take you
ahead.
back though too, because I thought I heard you say in the very beginning that you had a solution to pharma.
Oh, I do. Oh, I'm so glad you.
But I thought I heard like there was a pharma solution going to be presented.
I appreciate so much the question, Madam Secretary.
Brian, before we get to that, Ms. Narg, did you want to add anything on kind of the cost and affordability issue here?
Probably too much, but the one thing that jumped out to me is I would say that I'm sorry, I disagree a little bit about the copay because hopefully we have measures in place that if someone can't afford a $10, $20, $30 copayment that they're getting, and I know not everybody does, but they're getting some kind of subsidized secondary insurance that helps them pick up those costs. However, what I think a big piece of the system that's missing when we talk particularly about copayments or having zero copayments was the act of having an annual visit with your physician for a zero copayment, which a lot of people thought, well, that's great because people are going to be unhealthy. They're not going to want to spend money to go to the doctor. They're not, and exactly, I could see you shaking your head saying it was a big waste. I agree that it was a big waste because one thing that a lot of people I don't think realize is, as a patient, you cannot bring up anything during that visit without getting charged. You can go in and get your healthy care visit, and hopefully if somebody's blood pressure is high, or they're having problems with blood sugar, or one of their blood tests comes back, we hopefully catch that for the person who wouldn't have maybe not come in knowing that they had a copayment for that visit. However, the minute your doctor asks you how things are going and you bring up something that you're there now for to discuss, that becomes a bill.
Becomes treatment.
not only does it not become that you had to now have a copayment, it becomes a treatment, exactly. And then you end
I
up
literally tell my
getting-
husband when he goes for his annual physical exam, because he's a chatterer, I say, don't say anything.
That's counterproductive, right? Counterproductive to what we're trying to do about keeping people healthier and bringing people in to discuss things with their doctor. It's counterproductive. So we need to find a way where we get people to stay healthy and get their problems and their diagnoses recognized in a different fashion. But on top of that, since David asked, transparency of cost is really difficult too, and that comes into play, same thing that we're talking about with co-payments. Sure, you may think, and it's exorbitant, but, you know, yes, we're aware of what our deductibles are. We're aware that we have a 80-20 co-insurance or a 70-30 in co-insurance. But of what? As a consumer, and I know you don't like that word, but we are consuming something and paying for it. But as patients and consumers, we're not made aware up front of what the cost is going to be. So even someone with a subsidy who is paying a small fraction of that still doesn't know. And without transparency, patients can't make informed decisions. There's no price comparison since we're not in a standardized system where every hospital gets reimbursed at the same rate. Without any transparency, a patient can't say, well, I have to have a medical test done. Let me call up Mass General and ask them how much that's going to cost. Has anybody ever tried to do that? I've actually tried to do that with a mammogram a few years ago. Nobody can tell you. The only thing they can tell you is, well, once we bill it, you'll get a bill, and then we'll know how much it costs. But there is no other industry, and it's different from hospital system to hospital system, right? So you can't compare. But there is no other industry in our nation, in our state, in our nation, in the world that operates that way and gets away with it. If you compare that to, say, the retail world, retailers would never, ever get away with that. And in fact, the Attorney General's office has things like price labeling laws to protect us for that reason. So you can't go into CVS and say, pick up a tube of toothpaste and not have a price on it. You're able to ask someone exactly how much that's going to cost you. But when we talk about effective pricing and fair pricing, so to use that comparison again on a very small scale, you pick up that tube of toothpaste. Let's say it has a price tag on it for $2. You expect to pay $2. You go to the register, and all of a sudden it gets rung in, and they tell you, well, that's going to be $25. And you say, well, what? And they say, oh, well, it's not just $2. You have an ancillary service fee. What's the ancillary service fee, you say? Well, that's for the person at the register.
And you have a facility fee.
I'm getting there. To put it in a bag and hand it to you and actually ring it up for you. Then they say a portion of that is also the facility fee. And you say, a facility fee? What's that? Oh, the facility fee is to help us pay a portion of our rent. And I know we're all laughing, but that's exactly what happens in the healthcare industry. And in no other industry would anybody get away with non-disclosure of pricing. And I don't understand in this state how and why that's not something that's on the table. And when a patient can't make an informed decision because of transparency, the costs go up for everybody. And so if we can find a way to standardize that, I mean, we need state laws to mandate the transparency of how much healthcare is going to cost, let alone who is going to help subsidize that and help these patients.
Yeah.
I hope you're asking about pharmacy.
So, yeah, did you want to talk about the pharmacy, or do you, I'd be happy to go very quickly. So, you know, we think there's a lot that the state can do. Certainly the federal government, the FDA that we talked about yesterday, I don't want to minimize that. But what can the state actually do? We have 4 ideas we want to put on the table. The first one is transparency. So Vermont passed a statute requiring drug companies to report their cost basis and justify their price increases. Something like that ought to be done at the state level in Massachusetts. You know, drug costs right now are a total black box. It's totally cloaked, and we think it ought to be opened up. And we can see if the prices being charged are reasonable. We don't need the Attorney General to use her subpoena power to let everyone know what the tube of toothpaste costs. And we should know that for drug prices. Secondly, I want to raise the issue of drug price coupons, the discount coupons. So Massachusetts used to ban the coupons on the principle that they were not an effective way of reducing costs, but in fact, they spread the costs and make costs higher by discounting the copays, and this gets back to what we just talked about. When we decided to allow coupons, we passed a law requiring the old Division of Healthcare Finance and Policy to do a study, rather CHIA to do a study, and that study was never done, and it should be transferred to the HPC. So what we'd like to say is, let's do the study that was called for. I think when we do the study, we'll find that these coupons actually raise costs for everybody. And
There's
audit.
just a paper that came out about this yesterday.
There's a paper yesterday, the NBER,
Yeah.
and the conclusion of that paper was that drug coupons do actually raise costs in total. The third thing is the issue of the whining and dining of doctors by the drug companies. So we passed a law in Massachusetts saying that the meals that were provided by drug companies as part of their marketing efforts should be, quote, modest meals. But then the DPH, when they came to define what modest meals did, really went against the intent of the legislature and basically said that anything goes, even allowing alcohol to be served at, and basically, since that's a tax-deductible expense, marketing expense, we're paying for drug companies to be whining and dining these doctors. So we think going back to the original intent of limiting what can be spent on these marketing meals makes sense. And then the last thing, it's got a horrible name. It's called academic detailing, but it's actually a really good program. Senate Ways and Means looked at it last year. They found that investing $500,000 would save about $3 million. What this is providing objective, unbiased information to prescribers using the same techniques that the drug companies do on cost-effective use of prescription drugs. The funding for that has yo-yoed up and down over the years. It's just a little bit now focusing on opioid education, which is the exact right thing to focus on. We think if there were a permanent source of funding for that program, that could go a long way. So those are 4 ideas we want to put on the table.
Brian, I told you you could think about everything. Would you be willing to stay around for the prescription drug discussion?
Of course, absolutely.
Thank you.
Okay. Ron, as a quick question, because we're out of time.
And I look at the whole system as a patient, but I don't like the term patient because I don't pay the bill. And sometimes I think it shows. I prefer to be a client. And when I look at the medical system, it's like an alternative universe. And as a consumer, it's really difficult to be in the system, especially during an emergency where you're totally out of control, and then you're asked, who is the family advocate? Oh, I am, and I don't know how to spell medicine. Right? Doesn't work. So when you look at what we face, especially during emergencies, like what can be done to help us better understand and navigate a system that is a completely different world?
Whoa, and you only have a minute. Sorry.
So I'll offer one quick idea, which is patient navigators. Actually have that available to people, someone who is trained, who does know how to spell medicine and everything else, and can be there for consumers who need that help to get through the system. So I would think that's one, and the other thing is simplify the system, right? We could spend hours on that.
Yeah, and I would just add that patient coaches is another phrase that people use, and that's been used in a lot of places. You know, there are techniques to improve patient confidence and patient activation that seem to have a real impact on making shared decision-making work and having patients be more involved in their own care.
I want to know what insurance you have, Ron, that you're not paying the bill. Because the last thing oh, go ahead.
I'm not viewed as the person paying the bill.
Oh, okay, I misunderstood that then. Because I was going to say, you know, as the patient, for lack of a better word, or the caregiver actually, because in our instance, my patient, my daughter, is not paying any of the bills. My husband and myself are paying those bills out of our hard-earned dollars. But the system's got to be fixed. When you go into especially an emergent situation, the last thing you want to be thinking about is, oh my goodness, how much is this going to cost? And I hate to put it this way, but fortunately for our family and a good number of families in the state of Massachusetts, we're fortunate to live in Massachusetts because we have the subsidy of Mass Health for our complex kids and adults. And so fortunately, when I walk into an emergent or a primary situation with my daughter, I'm not thinking about that because I have the secondary insurance through Mass Health that's helping me with that. However, I will say that that's a system that still needs to be fixed because we do need to put some of that onus that was mentioned before on the primary insurers. Because I'll tell you right now, poor Mass Health pays a lot of things that my primary insurance should be paying for with a lot of loopholes, and they get away with it. And Mass Health, you know, isn't necessarily examining that. They just go, well, you have it, so here you go, and we'll pick up the difference for you. But, you know, if something ever happened to myself or my husband or another family member, I'd be in the same boat as Ron was talking about. You can find yourself in an emergent situation with a high deductible at a 70-30 or an 80-20, and you have no idea what's going to happen.
So I just, since you raise it, so Mass Health is a secondary payer, was one of those great consequences of the failed connector system. So when the system failed of the connector, since it was a joint eligibility system, every program integrity function for Mass Health around secondary payers also failed. It's being fixed, so you won't be seeing that anymore going forward, but that is one of those underlying costs that no one wants to admit when the connector failed, because we all wanted to just say people were getting insurance, people were getting insurance, people were getting insurance, instead of understanding that when the day we flipped the switch on the connector had significant fiscal constraints and impact on the Mass Health program. It's just now being fixed.
I would say it started before the connector as well,
Yeah.
because it was always there, and there was always an issue with them
Completely
backing
failed.
up the primary insurer.
Completely failed when the connector failed.
Well, thank you to this panel, which has really been, I think, taught us new perspectives and given us some things to think about. So I really appreciate what you've done.